and growing together.
Virtual, virtual reality in surgery is an advancing transformative tool enhancing both the education and practice of surgical procedure. It's my great pleasure to welcome Dr. Samir Ranjan Naik sir as the moderator of the talk, Professor and Head of Department, Department of Surgery, GSL Medical College and General Hospital.
Good morning. Welcome to the day 2 program for our the prestigious simulation program. Uh, this is my honor. This is a great privilege to me to introduce the Professor Dr. Avinash Supe. Uh, I just saw sir's biodata couple of almost days back. Same faculty almost, but sir is a consultant GI surgeon in Jain Hospital, Chembur. He was the ex-director, dean in the medical education and in the MCGM hospital in the Mumbai. He was the past president, Indian Association of the Surgical Gastroenterology. He was in the editorial
Sound?
board in some of the medical education.
No, the video sound.
And he received Dr. B.C. Roy prestigious award. Under
When it
his
comes, you'll play. Now it is.
high name, there are almost 9 books, 12 booklets, and 327 publications. So let us welcome Dr. Avinash Supe, sir. Sir, please.
Thank you. Thank you so much. I think good morning and welcome to the second day. I think today we will have a little different topic. There will be some amount of repetition, but today we are going to speak on virtual reality simulation in surgery, especially mainly virtual reality, but its relevance into the surgery, how it is going to be, because there is another debate by Dinkar and Aditya after this, so I'm sure we will talk about it later. Now I would like to thank simulation team, excellent workshop, excellent kind of an organization. I have no conflict of interest to declare. Now I'm sure virtual reality, this is a word which we use all the time.
Recording in progress.
And over years, you students, have been, and everybody is now excited about this new world. So virtual reality is an artificial environment experienced through sensory stimuli provided by a computer and in which one's actions partially determine what happens in the environment. Now this is a definition, and the VR as a term, virtual reality was coined by Sutherland in 1965. So the concept of virtual reality came much before in 1965. And over last 50 years or more than that, 60 years now, this has become now a reality. So the first virtual reality came when people started using for games. And I'm sure many of you must have used, especially Sony's PlayStations. And I'm sure many of you must be playing those various kinds of games. And these are PlayStation 5, PlayStation 4, all these are nothing but virtual reality games when you put those headsets and do it. Actually, if you see the virtual reality, it has been used into education extensively, interventional for public health promotions, pre-operative, intraoperative, post-operative, and engineering. So all places you find the virtual reality has been used very extensively. So the first came in virtual reality in surgery in 1997. If you really look at this paper of Annals of Royal College of Surgery, was MIST VR. That time the laparoscopy came in 1990 in a big way. And when laparoscopy came in 1993, there was a need for faculty development. That was a time when these kinds of programs came for training people about laparoscopic skills. So this was the first kind of an VR came. Then there were a lot of VR adopters. Many kind of faculty started adopting the virtual reality. And if you really look, surgery is amongst the most influential adopters of VR. And it is made up of 7.7% of all the VR related academia. So out of all VRs, this was the one which really did. And I'm sure if you really look at healthcare, healthcare is quite big. and look at the kind of business they are really making today. If you look at publications of VR and surgery, it's very interesting to see. You know, if you just type in PubMed virtual reality, the kind of publications you get, and if you type virtual reality and surgery, you know, you have almost about 1500 or publications. If you add augmented reality, you have more than 1000 publications. 3D printing also has more than 500 publications. So these are now coming up in a very big way. So PubMed, if you really see, is only one journal. There may be non-PubMed journals also. But the kind of literature, kind of interest people have is huge. And therefore, we should explore what it is really. So the first important part of any VR is the degree of immersion. How much you are immersed into this kind of an reality. And this is to achieve immersion or presence of 3D environment, VR must be successfully create a false perception. You know, I don't know how many of you have gone to Disneyland and you have gone to those panoramas and you have gone to Empire State Building where you have really flew down and you have seen the whole New York. These are all immersive kind of an VRs, you know. So the first is VR creates an illusion. So these are types of illusion. We must realize that achieve immersion is a type of illusion. So there are illusions are place illusions, plausibility illusions, and avatar embodied illusions. So these are the three types of illusions which are there. And this is somewhere from the wonderful paper from Sensors. Now place illusions is feeling being in a virtual environment even though you know you are not there. See, sometimes you go for these panoramas and you stand there and they take you to various kinds of surfing. They take you through Atlanta, Antarctica, and they take you through. You are at the same place, but you are moving around. Now that's kind of a place illusion, using interactions with the environment and receives the appropriate response. Look, you know, look, something like this. Then second is plausibility illusion. You know, you create a scenario that you are doing something. For example, here that person is just holding hands like this in real, but he is getting feeling that I am holding a rod and then I am trying to push that rod. This is a plausibility kind of illusion. So person might feel that a cube is falling towards these toes even though they know that events are digitally generated. So you are creating a movement of illusion. And the third is what is called as the avatar embodied illusion. This is a newer version where you see seeing it in the same location as your physical body. It's a complex phenomena that can be created using technology basing on many social VR experiences. And now this is also many times you see in movies or everywhere, these kind of things you see. The second important thing about VR is the degree of immersion. Whether you are in a non-immersion, semi-immersion or immersive. Now these are very important aspects. Let's go into one by one. Now if you go through the immersion, non-immersive is like using a desktop or a computer. You're using a computer, it's 2D computer, it's cheap and simple. Then you use a semi-immersive where you have a dynamic 3D, and then you have immersive systems which are very costly. I'm sure GSL is one institute where there is an immersive system which is not so cheap. Now look at these non-immersive systems. You know, these are non-immersive systems were there when we started working in 95. You know, that time many of you may not have been born, but that's the time when we started learning laparoscopy and we started using these techniques. And this was a type of VR we started using. You know, something like, if this works, yes. See, look at this. Now these are all semi-immersive surgeries where you can really feel the abdomen organ, you can really cut. Look at this, this is a gastric banding, that was a sleeve gastrectomy. All these surgeries you could do by semi-immersive techniques, and then you can really put a knot and you can learn how to do this. Then came these lap mentor immersive systems. Here you could really touch and you could really do a cholecystectomy. And with difficulties, you know, you could really dissect these tissues. And then you see, this is all virtual reality. You are doing all these surgeries of your own. And then you can make mistakes, as many, you get a feedback. Then look at this kind of a system. You know, this is a 3D vision you get. You can put a laparoscope and you can really go into the liver and you can touch liver. You can put on sound also if you have.
And reduce bleeding.
Okay. So you can really do resections if you want to do liver resections, cut a liver resection, and you can do all this. So these are all now easily available, and most of the people would like to do these kind of surgeries. Now, if I learn on this, then I'm a better surgeon when I normally can do it on your own. Now, this is immersive lab of GSL, which we saw yesterday. And what a lab. I mean, you have to really see all around. You are seeing instruments, you are seeing, you can convert it like this. And then you can really feel that you are in the deep of the ocean. And this is on your 3rd floor of your building. So, VR visual content is computer generated animations. User can actively participate and react in a real time. I can touch it and I can make a real time change. 360 degrees, recorded or live stitched, what have we called it. So, it could be flat screen. You know, if I want to do a laparoscopic surgery, it could be a flat screen. Or I can use the VR headsets. Now, look at this kind of a flat screen. This is just a 2D screen. I am doing a laparoscopic surgery, and now I am going to say I am to do intestine, I want to take it forward. Now, I try to do experiments with this. So, my hand movements become right. And then I learn my laparoscopy, and then I get it further so that I can do further. Of course, there are low fidelity also, but this is a very commonly done experiment which we used to do. Then this is what we call as a cave. You know, cave is cave automatic virtual environment, what we call as an immersive system. Look at that. They create complete world around you. This is also from the GSL lab. You can touch it and move it. You can start IV, you can create scenarios, and all this is virtual. You know, this is virtual reality which normally is done, and this is a picture from GSL lab. Now, the next component which came into virtual reality was haptic, visual, tactile, and vestibular. Because the three are very important components. I think I was just appreciating your immersive lab, Sandeep. So, visual, haptic, tactile, and vestibular is the new concept which came. Over, you have now visual feedback. Also, you have a desktop display, large-scale screens, phone-based hand mobile display, tethered hand mobile display, standard-alone hand mobile display, cave, which I showed you, and the eye dome, what they call it. Now, here you have haptic and vestibular kind of displays. In fact, today there is a virtual reality for vestibular rehabilitation. Those who are not able to hear and you want to restore their, rehabilitate them, you could have a special kind of a virtual reality. So, lot of new changes have come where the robotic shape displays, passive haptics, vestibular displays, these are all coming up in virtual reality. So, initially it was thought this is only a visual one, but today now they are adding various components of this into this reality. Now, this is a program which we do in our own hospital. This is called as a mind maze program. Now, this is for neuro rehabilitation. All those people who are recovering from stroke or paralysis, what we do, we give them this program. They sit here like this and they work on mind maze program. So, there is a haptic component involved into this. So, their neurological and physical recovery is much better. And this is now used all over the world. This was created by Hindujas, where I work with Hinduja Hospital. So, this was created by the Hinduja International. And now this is all over from John Hopkins to everywhere. So, these programs have helped to improve. These are all virtual reality programs. But you can see this is the way the person has to really tackle that, and he can improve his rehabilitation kind of a process. So, these are something which are very interesting things which are coming over a period of time. So there is a competition into that mind maze. He gets a score, he knows how he is doing, which elements he is doing well, which elements he is not doing well. So you know how to do physiotherapy. So these kind of feedbacks he go on getting. Then we are in an operating room, you will find, can be useful for everything. Pre-operative planning, operative guidance, post-operative complications, and you can predict all that. Now, for example, if you really see pre-operative planning, you can really find out what is the kind of an anatomy with meta-learning and AI. Intraoperative guidance you can get with VR. And of course, you can use so many other aspects also of VR in this. So, in a mixed reality, augmented reality, these are the words it will see. So, virtual reality is places use of another location entirely. Augmented reality is either you use Google Glass or Monocell to improve on mobile devices. And mixed reality is when somebody is having a physical plus virtual together. So this is the kind of a reality you see. And from no device to VR, there is a huge range of continuum to the extended reality. And this is where the world is now moving towards various aspects. Now look at this kind of a lever. Now I can, if I get a good image, I can create a lever like this image. And I can make it such a big, like this whole hall I can make that lever. And I can hold it with hand, rotate it, so that I know exactly where is the anatomy of that liver. Where is the hepatic veins? Where are the hepatic arteries? Where is the portal vein? When I'm going to dissect it, imagine I know the anatomy so well. And this will help me for doing a surgery. And you know, this is not very far. 3D printing, you have a 3D printing lab. You have this virtual creation which you can really do. Now look at, so these are they useful? So advancement in image processing, newly devised are traditional. This was something which was reviewed. They found it compatible. Now is the time they are being used as a routinely in many centers. So this was where the large virtual 3D images for learning, for interactive and sharing. Now let's go one step ahead. Now you have a lever like this. You create an image of lever. As I said, I can expand it. I can have to just hold with hands and expand it. And I can get a lever like this. And I see the anatomy is so clear. Now I want to do, say, right hepatectomy. And I want to cut that lever. So what I really do, I would like to create that half part of it, and then I keep it next to my operation theater, and I just put it like this. So this is the way I would like to work in laboratory, and I would like to cut that lever. And of course, I can do what is called as a 3D printing and intraoperative holographic navigation, it is called as. So I create an image of that holographic image, and I start working on this. And look at this kind of a video now. I create this half part, hold it in hand, and I keep it while I am operating. And I keep it by the side through my 3D vision. So when I am operating, I know exactly which artery is coming from where and where I am going to cut. So the chances of errors while doing surgery become less. So this is very fascinating. You know, previously I remember we used to keep a CT on the board and we used to operate. Then now we have got a 3D vision. Now the next thing is virtual reality image, and which is next to your thing. So I know exactly now at this 1 millimeter below my vessel is coming. So I'm more careful. So I put it down, I cling it, and so the bleeding is less. Now these are all finer things, you know, especially when you're talking. Then there are now VR operating room planners. They simulate changes of the whole OT. You can create a, so I know exactly team building, conflicts, the way I manage the whole team. All this can be done now through the VR layouts. Post-operative reflections, I mean, this is something is very important, that VR can advance reflection by helping healthcare professionals to relieve a situation that they have encountered. And they can rewatch themselves, find out what went right, what was wrong, what was not really done, how I could have improved my movements, how we could have improved the teamwork, all that can be reflected, and we can find out whether your processes are right or wrong. In fact, post-operative AI in reducing surgical errors. This is now becoming very common. Most of the people are deploying AI in hospital systems to reduce medical errors. And I mean, this is where, you know, surgery performed on 4-year-old's tongue instead of finger in Kerala. Now, this is a gross mistake. But you can really avoid all this by recognition of sight. So, when you come to the training and education, I think yesterday somebody really talked about it, that you have, whether it is accessible to everyone or costly, high fidelity versus low fidelity. Now, usually desktop and mobiles are accessible and they are low fidelity. Physical models are accessible, again high fidelity. Then sometimes cadavers and animal models are costly and they are high fidelity. And AR and VR is low fidelity, but they are also easily available. Now, the cost is an issue in VR, but slowly it is coming down and becoming accessible to everyone. There are a lot of examples of education when we normally do it. Teaching medical anatomy. I'm sure you have an anatomage, and I'll show you the image of that. Familiarization of surgical workflows, developing of technical skills, managing crisis scenarios. You know, I think these are becoming very important today. How do you manage mass casualties and crisis situations? Experiencing rare procedures, realistic decision making in virtual hospitals, and training for situational and spatial awareness. Now, this is something which is again important aspects. You know, non-technical skills, spatial awareness are very important. Though they are not directly surgical skills, they are impact on your development. And team training. So, these are important of all these realities. I'm sure you have all gone through this anatomage. And I saw anatomage in your anatomy hall. Now, this is not so common. Huh? 2 anatomages. So, I think that's where I feel the learning becomes so different, and it's good. So, many of you are lucky to learn anatomy on this. So, you did not go through those halls where it is smelling with formalin and the kind of eyes become red and you have to go through vomiting and all. So, these are something which are good environments where you learn, you know. I'll show you how people learn operative things, you know. Now, this is what is called as
augmented. The ureter is closest to the pink zone. The rectum is closest to the red zone. So our green zone in the midline is the one with the greatest safety zone with both the ureter and rectum at safe distances.
Well done. In what direction would you place the suture? Speak the color of the correct arrow.
When we're placing sutures, our area of maximal control is the entry point. So we're going to put our entry point from lateral to medial, as that's going to be closest to the ureter. So I'm going to choose the arrow from lateral to medial, or the red.
If you were to kink the ureter with one of the 3 sutures, which one is the most likely culprit?
The distal suture is the one very close to the ureter, and that would be the one to transiently obstruct the ureter.
So, if you really see, this is an interactive video. That student is wearing a VR set. She's interacting with the person and she's asking questions. Where will you put your suture? Which suture is going to be dangerous? Where will you avoid cautery? Imagine, these are the important intraoperative decisions which a postgraduate resident should learn. Now, if you are able to train them during this, I think that is what we want to bring safety to the hospitals, safety to our operation theatres. Now, if a student spends few hours before he does actual surgery, imagine the level of safety you bring to your operation theatres. And this is what is the advantage of these realities. And there are enough publications now in last 5 years which say that these are all in various organ transplantation, surgical training, orthopedics, emergency medicine, maxillofacial surgery, all surgeries, this has been found to be very useful. And the 3D holograms and liver, I'm sure holograms are also being used, and mixed reality, how it is being really used. Now, another thing which they use
Students
in the
are
Korea,
performing
I
the
went to
same
one
surgery,
Korea to see
but
this.
on an artificial lung. On the left, the real operation. On the right, an organ created by a success. The tumours are removed and it's time to compare.
So what they
Then
really do,
doctors make the final touches.
there is a
to
surgeon who is operating,
operations.
and before, on one day before, they have created a 3D image of the patient before. So in an operation table, there are two tables. With one system, the surgeon is operating. Other system, the other resident's team is operating, and they are operating in the same way, looking at their boss into a 3D completely patient, printed patient. So they know exactly the anatomy, and they would ligate that, and when the surgeon removes that thymus, they will also remove that thymus. So this is the most practical experience, and this is printed with all this. So these are the newer methods of surgery which people do. So another thing they will do is AI and ML will analyze investigations, they will predict difficulty, guide you on port placements. Now mixed reality, I think I showed this video yesterday partially, but whenever there is a delivery, you can really see how these realities can really make you realize how they deliver a baby, and that's the way they can really learn.
The group is going to be understanding the same reality. So now the instructor can really focus on how to manage a complication. Nothing ever has provided that level of information. It's not a textbook, it's not a video, it's not a PowerPoint presentation that's going to give you that kind of understanding. CA Healthcare selected shoulder dystocia as the first scenario on Lucina AR because it's a rare complication of delivery, but it's one that's difficult to manage. You have a number of options, you need to think fast. Seeing the anatomy, seeing the progression of the baby in the birthing canal, and seeing where the shoulder gets stuck is going to be very helpful to understand how to fix it. Seeing them in front of your very eyes as a student is like a revelation, right? This is the future of healthcare education. Really beyond the spectacular of that experience, there's an educational purpose that we're fulfilling, and that.
Look at the smile on those students' face, and look at that you don't have to really damage those babies to learn. You know, sometimes if they're doing and they get hypoxia, you know, for lifelong you feel that you have created them. So this is something where you can learn, expertise yourself, and then go into this. Then look at these kind of virtual autopsies. Autopsies is very commonly done now with this. So if you really see today, when during COVID time we realized that we did not do autopsies, but autopsy was so important in COVID times. So this could have been done with the virtual autopsy to see how much is the lung involvement. So what are the limitations of VR? We need more data to prove clinical utility of VR. Though we have some data today, we need more robust RCTs and everything. Cost is a major issue. Efficiency and effectiveness of VR training simulators. And cyber sickness, this was a term I learned yesterday, that some of the students do get cyber sick, you know, of using too much of this. But it's a question of, I think, maybe my generation, which is the old generation, maybe getting a cyber sick. You are all, I think, generation Z and millennials. I'm sure you don't get cyber sick. And you can watch mobile for hours together and troll into others' life again and again, which we don't like actually sometimes. So this is the way artificial intelligence pays. There are pros and cons. Every system has its own pros and cons. Privacy and curated healthcare data, which everybody has to really understand is a problem. Now, I'm sure the future direction is HoloLens-based surgery. You know, nowadays surgeries are done by HoloLens, orthopedic surgeries, you know. basically this operation is done. Now look at this robotic assistance. This is a new video where the AI will help me to operate through when I'm doing a robotic surgery. It will develop planes for me, and it will tell me that this is the right direction of plane, and I can really dissect this. You know, this is called as a Eureka. This is a new system where they really do it. Then captive microscope for brain surgery. You know, real-time imaging to reduce intraoperative disruptions. People are using virtual reality to find out how do you really do these surgeries. Then VR is also used in nursing education extensively. If you really see, nursing education is much ahead of our education at times, and they do so much of work into VR that it is worth listening what they really do. In fact, today I want to introduce to you that even in India today, we have a virtual reality in healthcare, and Aditya is here who is going to speak about it. So this is now done in Chennai based and Pondicherry based, where they have introduced this medicine VR, where they do it in medicine, they also do in nursing and AHS, and they are coming in the hospitals. So I think IIT Chennai and their company has made it. So I'm so proud this is a Make in India kind of a product, where slowly they will also try to bring the cost down and make it more accessible and affordable. So I think these are the kind of innovations which we should really start looking at them and try to see how this is being done. What is the future? I think I was told HoloLens has stopped their production, but the future may be Apple Provision. Though it is costly at this stage, over a period of time, I'm sure Apple will bring out with a low cost future vision, and it would have to, I don't need this then computer, I'm just going to use Apple Provision and just going to further my slides like this with my hands, and that is not very far. And I'm sure in summary, VR is emerging as an educational strategy and a surgical support tool. Recent advances in software and hardware have reduced consumer cost and allowed better use immersion. VR is now both accessible and affordable, increase adoption in future, but of course the cost needs to come down more for a government hospital like mine. I'm sure you must really understand that. But it's an inter-reality which matters today. It's not the virtual reality. You have to have a mixed reality. Inter-reality is a new word which we use, where we need to integrate it with other emerging technologies, and that is the vision of inter-reality. So this is a new word which normally we use, and it means coexistence of virtual world with the real world. And if you are able to do this, I'm sure we can do a better thing. So thank you so much, and I'm ready to take any questions.
This is our future now. We have to stay in the virtual reality, and the training program most of all in the future is with the virtual reality. So this is a mesmerizing talk. Any questions, anything from the audience? Sir.
Yes, Murthy sir.
Sir, that was very comprehensive take on VR. Now, where do you see this in endoluminal surgery? Where do you see this going in endoluminal surgery? Because most of the world bodies have now started recognizing VR as a viable tool to modify our current practice, surgical practice.
Sure. I think I did not really talk about it because yesterday I showed that endo robotics picture, Colubrix, MX, all these are the new techniques which are coming up where people use this inter-reality with the colonoscopy and upper GI for the third space endoscopies, and they have really made life easy for them. Actually, what we are really worried about in a third space endoscopy today is the depth at which people operate. Now, this depth is better managed. I showed you like Eureka in the robotics. So, if you now have a depth control in a third space endoscopy, then the chances of complications will be less. Secondly, smaller polyps, smaller surgeries. In fact, people are doing now even appendix and all through the endorobotics. So, you are mixing it and you can just put a colonoscope, internally you make an opening, you pull the appendix down and then you take a suture inside and bring the appendix through the rectum. Now, this is all becoming, I mean, these are all, we are seeing experiments. You know, when notes came about say in 2000, we had a lot of hopes, but it did not work well. you know, notes went down. People did not use notes. But with this endorobotics and this reality, the lower colon, lower rectal surgeries, where there are smaller polyps, especially the third space endoscopies, and some of these surgeries will now continue to change. And they are now working. There's a good amount of work being done, and people have started using this, and they're avoiding major surgeries for this through
So
this.
then there is a cost argument in there. You have made it very valid argument there. If you are going to do colonoscopic retrieval of appendix, you will avoid a GA, won't
Yes.
you? It's
Yes,
done under sedation.
Yes, of course it will make. See, cost is one issue which I always look at it, that when the cost of development is very high, but when the users expand and the use is more, then I always feel the cost becomes lesser and lesser. I mean, sure, when laptop came, we all used to feel, will I get a laptop in my life? Will we be able to afford a laptop? Will I be able to afford a tab? I'm talking about 2000, when the laptops were there, desktops were there. You know, I paid my 3 times the salary of mine to buy my first computer by taking a loan. You remember that in 1988 or something.
And now in the front row, none of us have a laptop. We have done
They are
away
all
with
tabs
laptops.
and mobiles.
We
Our
are all
mobiles,
on Apple
our
devices
mobiles
now.
are better computers today. So I think technology, the way it is growing and the revolution is occurring, I'm sure this cost will come down. Sure.
Thank you, sir. Thank you for presentations. We'll move to the next session.
Thank you, Dr. Avinash Supe sir and Samir sir. Our next event for the day is a talk on newer technologies in basic sciences by Dr. Adit Chinnaswamy sir. Our moderator is Dr. Ahmedullah Sharif sir. He's a professor, head of the Department of Anatomy, AIIMS, New Delhi. Dr. Sharif sir has been celebrated for his innovative contributions to digital health and has worked directly with communities to improve public health. Please welcome Dr. Ahmedullah Sharif sir.
Yeah, of course.
Good morning, all of you.
Just next slide. All right.
Now I have a pleasant privilege of introducing Dr. Aditya Chinnaswamy, who is a minimal access surgeon and the co-founder of Medisim VR. He is at the forefront of reshaping medical education with VR and AI-driven upskilling solutions. He is a graduate of prestigious Sri Ramachandra Medical College and a co-founder of Medisim VR at IIT Madras. Medisim VR has established itself as one of the world leaders in virtual reality-based simulation training with virtual reality skill labs in many India's top medical institutions and established a strategic partnership with leading experts from the Harvard Medical School, the NHS, and global organizations like Hartford Healthcare and also with the government of India. So I welcome Dr. Aditya Chinnaswamy to deliver his talk. Thank you.
Right. Thank you, sir. Good morning, everyone. Very happy to be here. And thank you, Dr. Sandeep, sir, and Dr. Dinkapai for giving me this opportunity and the forum to speak about a subject which is very close to my heart. Basically, how are we going to introduce newer technologies to the basic sciences education, especially in the healthcare field. To get started, I think I'm following Dr. Avinash Supe sir, who has given an outstanding talk and laid the foundation very well and probably touched upon a lot of areas which I'm going to dive into as well. We've been looking at virtual reality as a concept for a very long time. I would say decades. And we've probably all come across various concept videos. And in this case, we always look at where virtual reality can actually be used when it comes to medicine. What are the practical applications of this kind of technology? And of course, during the course of my talk, I will touch upon virtual reality, all the extended members of the family, augmented reality, haptics, extended reality, and so forth. When we're looking at virtual reality in medicine, there are a plethora of places where it's already making an impact. Surgical training has been the pioneer when it comes to adopting virtual reality. I think Supe sir already spoken at length about it. Some of the other areas which are also in direct contention in terms of training medical graduates is skill training, clinical training, educational content. And there are also certain areas of clinical utilization when it comes to therapy. So we are now being used in psychology, treatment of mental disorders, phobias, pain management, and so forth. And we have patient education as another area where it's being utilized to sensitize patients to the experience they may go through during their course in the healthcare system. This has shown significant reduction in pre-op anxiety levels, leading to better surgical outcomes. But for the sake of today's talk, I will focus on these three main areas. So this is pretty much the three pillars of our undergraduate education. We have theoretical learning, which broadly encompasses anatomy, physiology, where we learn about the concepts and so forth. Then you have your clinical training, where you learn how to interact with patients, pick up clinical skills, diagnostic skills, and so forth. And then you have your skill training. This is now becoming a major area of focus. This was something which we always did on the go during the past few decades. Even at the time when I was a student, we did not really have too many colleges with functional skill training labs. We often learned on the patients. This was considered an acceptable norm back then. You said you couldn't be a good physician if you hadn't killed a few patients, and then that's how you learn. But now that can no longer be acceptable, especially when you have alternate methods to train without injuring the patients. So that's where skill training comes in, another area of focus. So today we'll take a deeper look into where virtual reality can create an impact in these three areas. I think before that, I think like Sir mentioned, the first study for virtual reality actually happened in 1997. If you actually go back and look at literature as to when virtual reality as a concept was even thought of, the first one is actually this machine that you see on the left, which is the Sensorama, where the user had an immersive experience of looking at 10 videos. This was sponsored by Coca-Cola back in 1957. But for whatever reason after that, they really could not take it anywhere forward. The other one to the left that you can see here is actually what they developed as a first entirely head-mounted display. And this was way back in 1970s. This was done for pilots. And as you can clearly see, we have come a long way from then in terms of what the virtual reality headsets are now. And I think we will move a long way forward as well. So the problem with that was that pilots couldn't wear that for more than 5 minutes without it causing them severe trauma in the neck. And they came up with the term of super cockpits for that, which was, I would say, a misnomer, but nevertheless, it was the initial attempts or foray into exploring this kind of technology. Here, we've all spoken about how virtual reality can actually make a bigger impact to the student base. And I think where that creates a bigger impact is we have had a lot of training methodology which have promoted passive learning over the course of time. It started with printed material. Now you have computers, virtual learning, all of that. But now we have all realized that the more engaged the user is, that is where the better learning outcomes are prevalent. And that is where you have virtual reality. So now when you go into where the applications are, the major concepts I'd like to touch about today would be your theoretical concepts. So when you're talking about theoretical concepts, those are essentially your first year, second year subjects, and the value of that recedes a bit as you move further down. But I would say maybe during your preclinical years, this forms the bulk, maybe 70–80% of your time is spent on this. And why virtual reality makes a very big impact when it comes to anatomy per se, because as a first year student, I really struggled when it came to understanding the spatial relationships between various organs. You want to understand the boundary, what it rests on, what's the posterior relation, what's the anterior relation. Virtual reality's specialty is that it allows you to take up any spatial position inside a created environment, meaning you can be whichever organ you so choose and look at what's in front of you, what's behind you, turn around and look at all of that. So that gives you a great way of understanding whatever happens around you and also starting to interact with all the organs around. And of course, there were a lot of initial, when virtual reality had its second wave. This was back in 2018, 2019, where everyone focused on creating mesmerizing visual appearances where you could, swim through the arteries, look at the lung from the inside. Those were all, I think, predominantly trying to educate or entice the masses about the visual aspects or the visual appeal of it. But since then, we have also understood that that forms an integral aspect of the user interface. Kind of understanding how the user can derive value from it and engage with the content becomes equally appealing. And that is where you have respiratory mechanics, cellular activities. Understanding of those concepts at a very basic level is made a lot easier. And then you have your skill training. And with skill training, we'll go into it in greater depth in the coming slides. Clinical training would be the same. I think we have another talk on AI patients later on. When it comes to VR anatomy, see, this is exactly what we were talking about in terms of being able to take organs apart, turn it around. I think you can open it, zoom. All of this is possible. And now with the advent of very good internet connectivity, people from multiple places can come in and take a look at whatever is happening. You can have shared sessions between people in remote locations, meaning knowledge share also becomes very easily possible in the VR environment. So here, this is one of the initial products which came out in the VR, to bring out VR in bring out anatomy in a VR environment. This showcases each of the organs being split apart. You can see that multiple systems have been built. This is a very theoretical approach to learning. And this is again something which is available on all VR headsets now as an individual student purchase option. Hold on, sorry. And now moving on to skill training. So skill training, when we talk about, we are looking at how NMC has now mandated a list of what they term as mandatory competencies for all of you. I'm sure, and I've had the chance to visit the lab yesterday, you're amongst the select few or privileged medical students, I would say, who have access to these kind of facilities where you can go in and learn how to perform skills on task trainers and VR and so forth at a regular basis. What this entails is basically any particular patient skill, starting from how you interact or assess a patient at the start, all the way to how do you put in a catheter, how do you manage IV lines, how do you perform an ECG, how do you interpret the ECG, lead positioning, so forth. And all of this has become a mainstay now. Multiple institutions are making it a part of the clinical rotations to actually be able to visit or spend time at the skill lab and be able to manage achieving a particular level of competency in all these skills. I'll take you through a small video of how skill training is done in virtual reality. So whatever you see here is actually the immersive environment inside which what the individual person can be viewing. And it's almost always a little difficult to translate virtual reality experiences to the 2D screen, because you're looking at what the person would see in an entire environment as a small screen grab. So you can see that there's a very protocol-driven approach here. You go step by step. There are two segments to the learning itself. One is where it is entirely about learning a new skill. You are taught step by step as to what can be done, what should be done, and you're not allowed to deviate from a particular norm. At the same time, after you do that, there's also cognitive learning aspects that occur in between it. We have various ways in which you can actually have knowledge imparted to the students during the course of the procedure without it having to come in the form of a didactic lecture or learning material taken up separately. And also this gives a very thorough understanding of the protocol, which is sometimes very challenging to achieve, especially when we bank entirely on traditional training systems, which were essentially designed for smaller cohort learning, and there's a huge dependency on the time of the trainers, which is where we hope this kind of technology can leverage the way the trainers spend time with the students. And with all of this, a common refrain always is there are multiple questions asked. One is, of course, the efficacy, whether it actually reaches the students. Are students just playing games on VR? So this was actually a study which was conducted in India. I would particularly like to quote this study because this shows that after 6 months, the learning retention outcomes were higher in students who trained on VR and mannequins rather than just as a single form of task training methodology. And now I'd like to move on to augmented reality. Augmented reality as a technology is something which allows you to integrate certain aspects of virtual components to your existing environment. Especially, as you can see, this is going to play a major role when it comes to learning anatomy and even in assisting during surgery. I think there are several use cases in the real world when it especially comes to augmented reality. There are multiple places where they're actually able to look at an object and provide assistance to the person who is actually looking at certain objects in the industry with information outlay. I'm sure all of you have seen this in movies. Iron Man comes to mind, and that is, a lot of movies have always been the inspiration for these kind of technologies, or it works both ways. And the the Apple Vision Pro, as Sir showed you a picture of, is actually a step in the direction where all headsets are going to become extended reality headsets. You're not going, the barriers between what is going to be virtual reality, what's going to be augmented reality, what's going to be extended is all going to come down. The same kind of hardware will start delivering all of this to you. Let me run a small, yeah. So these are things where you can have it, when you're wearing your augmented reality headset, you can have multiple options open to you. This clearly showcases a video where someone is already looking at a textbook in their study room, but also able to visualize a heart and understand its working. And we come to the next biggie, right? Artificial intelligence. You've heard this term everywhere. I'm sure all of you are using ChatGPT already for your assignments. That's become the norm nowadays, and it really wouldn't be fair on our part if we didn't use it, because that is going to be how all industries are working. We should figure out the productive way to using it. And that said, we'll look at how that is going to impact medical learning at present. So when we're looking at artificial intelligence, that's actually an umbrella term for the simulation of any kind of human intelligence that we were able to do but machines couldn't. Making judgment calls, understanding and then replicating that particular knowledge and applying those knowledges to various other fields where it has not been directly fed data. So one of the major areas where AI is making a big impact is the feedback and assessment. This marries in with whatever form of training you're doing, be it virtual reality-based skill training or augmented reality-based learning. And then now you have the next gen. ChatGPT recently announced a feature where you can have voice conversations with it. It is not yet financially viable for large-scale adoption, but this is going to be the norm in the future. So this means you'll be able to start having conversations, vocal conversations with AI and AI-enabled software, which means you can have interactions with virtual patients. So this allows you to practice history taking. You know, when I know that in most institutions now, we have huge student loads, and meaning patients are reluctant once you cross 2 or 3 cycles with them. First time they're very happy to speak to a student. They give you, a detailed history. Second time, not so much. By the third time, they start like frowning at you when you come and start asking them questions. So that is where this becomes something which will be very, very useful to have in your armory. Imagine you have your clinicals coming up, and just the day before that evening, if you can have a conversation with a patient, with this particular scenario or this particular diagnosis, and practice history taking with that. All patients are not going to be available at the wards at all times. This will make that impact. So this is actually a VR environment where the user is, an AR environment where the user is wearing a HoloLens and looking at a virtual patient and trying to have a conversation with them. The power of AI is that it understands open-ended questions. Earlier, you could not get away with this because you had to either ask very particular questions which would trigger particular answers. If you deviated from the norm, the system wouldn't have the capacity to answer, or it would say rephrase the question. And then that's where this changes. So even if you were to utter nonsense to the patient would at least call you out on it and then tell you to ask it relevant questions. And the next part is your AI-powered analytics. There's been a recent NMC change where there was also institutions to start assessing the competency of the skills in which the students are being trained. Currently, the competency assessment usually occurs through MCQs and maybe one-on-one sessions with the trainer. That is something which is not replicable at a large scale, especially when you're looking at student cohorts up to 250 students per batch. How many skills can a faculty realistically assess every academic year? So that is where AI-powered analytics and virtual reality-based training will make a huge impact. As you can see in this, there are 2 particular ways we are splitting AI-powered analytics. One is your performance analysis, which is to the far side of the screen, where you have immediate competency assessment report delivered right at the end of your attempt at a particular skill. That shows a report which was generated in our system after a catheterization attempt. You can see that the student scored 65%, but it also shows where the student did not make the mistake. This allows for repeated practice by the student without having to depend on a trainer to actually be present every time they want to. So this is where repetition becomes something which can be adopted by the mainstream. And of course, the other part of AI-powered analytics is also that you will be able to, you will have so much data in the background now. That is one thing which virtual reality does, is the amount of data it collects in an entire environment is phenomenal. And that data can only be made sense by artificial intelligence. It is way too much for the human mind to track. And now the AI intelligence engine can actually come back and tell you that protocol-wise, this is where all the students are struggling, so you may have to rethink your teaching approach and see if that particular area can be an area of focus when you're dealing with a particular cohort. So these kind of pattern recognitions happen in a large data cohort is made possible, especially when you marry AI with certain particular training systems. And one of the main misnomers, the questions which are, which always come is, when we speak about AI, is it an AI product? Is this AI? That is not that kind of singular singularity in how AI is going to be delivered is not how AI is envisioned. AI will become an essential cog in multiple products, allowing you to do things with those products which you never thought were capable. And of course, moving on, we're moving to another area where there's a lot of talk and noise around. One is the haptics aspect of it. This has again been around for quite some time. Everyone considers haptics as the missing element in overall adoption of these kind of immersive technologies. You have wearable haptics, which are the wearable gloves, meaning once you wear those gloves, you can see right behind the, I apologize for the image quality, but yeah, there you go. You can see that once the fingers are there, there's an exoskeleton behind the fingers in terms of the attachment. And these will control how much your fingers can approximate. Meaning, if you were to hold a bone, it would allow your fingers to not come any closer than a particular circumference. And if you are holding a liver, it will generate gradual pressure, meaning you can gradually increase the tension, at the same time giving you the feel of actually handling an organ. While that is one type of haptics, the other one is your force feedback. This is very essential for surgeons. I think this is also the cornerstone of a lot of surgical simulators, meaning you can get the force feedback of how it feels to interact with various instruments through your, various organs through your instruments. Meaning if you were to put pressure against your kidney during a nephrectomy, you would have a particular type of pressure. At the same time, if you were to put the tip of the instrument pushing against your liver or the spleen, it can generate differential types of pressure. And the third one is the holograms. This is something which is quite far from coming into the mainstream right now. With current advances with the graphic interfaces by NVIDIA and also all the AI computational capabilities increasing, we may see it being fast-tracked to a few years from now. This will essentially mean you can pull up any image. Again, I think the reference movie for this for a lot of you would be Iron Man again. You could see him pulling up multiple structures, playing around with engines, playing around with machinery, reassembling parts, all of that being done by visual images or structures floating around in air with no other wearables attached to the human eye. So that is where I think, again, there's going to be an intermarrying of a lot of these technologies between VR and AR and then subsequently holographs, and then the wearable aspects of it coming in with haptics. So when we look at all this, right, what would be the vision for us as medical education educators at a very grassroots level? I would say we understand what the three core pillars of undergraduate medical education are: theoretical learning, skill training, and then clinical training as well. We are now at I would say crossroads, or at a very important junction in terms of where the technology has arrived in now providing us the capacity to bring all of this into a single platform. We've never had that capacity or the capability before. So imagine a world where you can put on a headset, split the organ apart, learn the anatomy, learn the physiology, move on to your clinical training, start interacting with virtual patients, get the history, diagnose, so forth, and then realize that the patient needs a particular skill performed on them. Go into skill training, perform the skill, and all of that can be brought into the same headset now. And that is where probably I would say virtual reality sits bang at the center of these three pillars and provides us a way to harness all of this into the same headset. When we speak about all of this, right, there's one of the things that we've been discussing over is, when is it actually going to arrive? And I thought, like, a meme would probably connect with you guys better, and this might be a slightly outdated meme as well. Mr. Bean waiting by the side of the road for something which has not come. And We've been waiting and waiting for this to happen for quite some time. I think the first time we actually saw these kind of concept videos was way back in 2000s. Like Sir pointed out, first concept study in virtual reality, 1997. And yesterday there was another slide, which showed that there's an initial acceleration of expectations and then a dip where we understand what the technology is actually capable of, and then you come up back to the plateau of productivity, as Sir put it. And I think that is where we are at now, being able to actually realize that whatever happens from now on, we are moving towards a very cohesive way in which all of this can be delivered to the medical students. And I actually wanted to show that while we think that's the future, these things are already happening. So this is the virtual reality lab at Sri Ramachandra in Chennai. It's inaugurated recently. Students can walk in, try out any type of VR skills that they are looking at. You guys have a very impressive immersive room, a 4D anatomy table as well. So these are all ways in which newer technology is actually being brought in, and though it has not reached the entire bandwidth of students, I think we would say the top few institutions have started the adoption cycle of this next generation of technology, meaning this will become the norm in the years to come. And with that, I would like to conclude my presentation. Thank you for the opportunity and open to any questions.
Thank you, Dr. Chinnaswamy, for a very interesting and a good overview of the technologies that are touching the lives of the medical students in theoretical learning, skill training, and also in clinical training. So very interesting and very nicely covered all the areas. And I think those are a very, I should say brief, but very illustrative overview of the technologies. I'm sure audience will have a lot of questions for Dr. Chinnaswamy.
I think Aditya, now that you have started using this, can you tell me exactly where you have started using, in which modules in our country, and what is your experience from students as well as faculty?
Understood. So in terms of current utilization, we have around 40 modules in the library. These are essentially whatever the NMC mandates, or it's part of the UGC curriculum. This involves basic skills right from initial patient assessment to how to put in an IV line, like the small clip that you saw, putting in catheters, nasogastric tubes, ECGs, ABGs, ulcers. So whatever is mandated for at an undergraduate level by each of the departments is now part of the existing library. In terms of student engagement, I would say students love it, that there's a certain amount of gamification involved in this, and obviously the engagement factor is very high for newer technologies with students. I would say the long-term retention with students is also better. There have been times where students have started utilizing it like a library. When they want to do a catheterization, just before that, they don't have to be dependent on anyone. Just walk in, just go through the module once, understand, just remember all the steps, and then go and be a little more confident when they're doing the actual procedure. And faculty buy-in is an area where we are putting in a lot of effort to. I think this is, there's two segments to it. One, I would say faculty are extremely enthused by the fact that it takes away or it saves them a lot of time. We take away the onus of having to do the competency assessment, even like repeated training sessions at a very undergraduate level, which maybe super specialty surgeons and specialty surgeons are not very fond of that, imparting that kind of training. So they're very, very open to receiving it and like putting it on the ground. In terms of actual utilization for themselves, there is a particular learning curve attached to the technology as well. It's usually around 15-20 minutes, but that also where when people are not tech friendly, it is a little challenging and it does become a little intimidating for them. So that is the initial barrier that we have to cross, but after that, I think it's relatively smooth sailing.
Adit, very good talk. I think a superb overview of these newer technologies. I just wanted to ask you, where do you see your company 5 years down the line? Now you have, as you said, essentially focused on undergraduate skills. In terms of simulation-based education, where do you see the greatest application of this technology?
Wonderful. Greatest application of this technology is a question, and my company in 5 years is a question. But my company in 5 years, I see us becoming a platform company, both in terms of being able to allow medical experts to create their own content on our platform and making it specific to, tailoring it to their needs, and at the same time being able to aggregate as many different solutions, because the medical world as a whole in terms of what the training requirements are is so vast that it cannot be one player providing all of that. So we want to become the instrument and enable as much of that happening as possible. In terms of what the 5-year roadmap for the technology would be is, I would say that it is something where this becomes a quintessential learning tool when they walk into an institution, like how certain institutions promise iPads and thing to all the students. This becomes another tool that can be given to students with all the educational material required. So once you cover these three for undergraduate learning, that becomes the starting point. And once students start learning this way, that's when buy-in for postgraduates and super specialties increases. Trying to directly bring them on to a newer technology will be a lot more challenging if we start at that level, but if you start training them young at a particular technology, they're going to be more open and receptive to it 5 years or 6 years down the line when they become postgraduates and trainers.
So if I understand you correctly, right now the way when students are entering medical course, we are providing them with the textbooks, etc. Now we have graduated, giving them iPads. So next time when the students come, they'll be given a VR headset as the moment they enter the institution.
Absolutely, I think that's a natural progression in terms of where the tech is going.
Okay, I'm going to ask you a slightly more difficult question. Dr. Pilot you off easily.
Sure.
Why are you concentrating on training when there is a bigger opportunity? Now, there is a serious problem in the West which will creep up here very quickly. AI in radiology, imaging. You are the dead ringer for most of the users that they have. So why is it that you are concentrating on smaller market of training than day-to-day clinical function?
I would again say that is a different silo altogether. In terms of just using the technology to image is one aspect of it, which is just a visual representation, if that's what you're getting. While you're looking at how utilizing AI overall for radiology, that becomes a image-based, data-based game where you train systems, and then that doesn't involve the training aspects at all. That involves entirely the clinical scenarios. That then becomes a question of company focus as to where we want to get into.
Good morning. Congratulations on the talk. At SRM, are you done with cadaveric dissection, or is it only simulation based?
Sorry ma'am, I didn't get the question.
At SRM, are you done with cadaveric dissection? Is it only simulation based?
No. I think there is value to still retaining certain previous forms of training as well. Maybe the entire phasing out will take some time. That we do not see it happening right away. Maybe in a few years' time, but I think this is a step in that direction. We will see that becoming the norm in a few years.
If such a thing happens, I think they can as well sit at home. They need not come to college till basics are over, till anatomy, physio is over.
the value to we attach to peer learning and college atmosphere also has to evolve. I think just like how we are evolving in terms of understanding what is the core areas of training when it comes to a health graduate, how the health graduate might apply his knowledge after he graduates also has to evolve. Meaning a university will start looking at not just these three core concepts as the be all and end all of medical education, but also what are all the fields around it, where all they should look to leverage their knowledge. So overall university style learning, which is not usually the norm in Indian institutions, but is very heavily present in the West, will start creeping in here as well.
Any more questions, please? Yeah, please get the mic here.
I missed part of the talk. I was there towards the end. But I'm taking from what Dr. Dinkar was asking. We have now various platforms available. So you come with VR, we have options for them to learn through LMS. They have modular skill trainers which they can practice. So the only problem as we find as educators is there are any number of problems. If you have one problem, there are any number of solutions available. And there is not much integration which is happening at that level. Everybody comes up and says that my solution is the best solution. And it becomes too many choices for us to make and too many ways to diversify the existing resources. Do you think that there is a chance that there can be a collaboration which can happen at that level and which will make resources much more efficient to use?
Yes. It's a very good question, ma'am. I would say that is a two-stage process. The integration has to first happen on the requirement side. I think once certain case scenarios at institutions prevail, saying an institution or medical institution can showcase that this is how we integrated all these technologies and we cut the clutter, we removed some of the rest, and we have showed a working model of these technologies put together gave me the best result, then automatically the industry will follow suit, saying this is what provides value to the end user, this is how we have to integrate everything. So I think we are at the starting stages of that with, I would say, we are, from a very personal point of view, we are integrating some of the existing skill training labs and our VR lab in institutions. So this is, I would say, step one to doing that. Another thing that we are doing now is we are taking up operations of the skill training component itself for certain institutions. So when we do take up an entire silo, then integration at the institution becomes a lot easier. And when we do this for a certain period of time, that is when like a well-oiled or like a well-polished final solution will emerge.
Maybe we should take that up as part of HSDC.
Sure, ma'am. Definitely.
Any more questions? Yeah, please.
Sandeep, sir. Wonderful talk, Adit, congrats on that. Just to understand if you envision a future where, I mean, you all obviously have an entirely VR-based product here and which is working phenomenally well. But do you see a future where you integrate it with augmented reality so that, you can, so the knowledge component here is validated and it's objectified, but do you see where you can integrate it and you can achieve, based on the task as well, like how the students perform and objectify it, so that there's no two different forms of training. Absolutely. As opposed to, I mean, we have archaic models of simulation that we already use, but when it comes to technology, we don't want to, bifurcate it further and,
Absolutely.
Keep on repeating the same task on different levels. So I want to understand if that is possible on your timeline. Yeah. Thanks.
Absolutely. Thank you for the question, sir. I would say that absolutely yes, because the industry norm now is that all virtual reality headsets are capable of extended reality. So that by itself means everyone is now working in a way where all of these technologies are going to come into a single stream. It's not going to parallelly develop and start specializing away from each other. It is actually multiple things started, but at the end, it's all going to be on only extended reality headsets. I think Vision Pro is a significant step in that direction. We will have more and more players following suit from that, where 2-3 years down the line, there will only be one type of headsets, which the same headset will be capable of having a VR mode where it disconnects you from the surroundings, at the same time an AR mode and an XR mode where it will keep you around. And in terms of development, I would say that it's pretty much the same pipeline. Whatever assets and this thing is built for a VR world is individually portable into the AR world as well. So there's no major, this becomes a stepping stone to building anything that you can put in an AR world. So that way, it's a common trend, and it's almost an industry given now that everyone has decided that this is how we are going to work. It's a very natural progression. Absolutely. Whatever we are building is very, very, I would say, platform agnostic. One of my co-founders, our CTO, is actually built his first AR app back in 2010. So that was an age at which I didn't even know that AR existed. And there's never been a question where we've entirely dissociated the development teams. It requires the same expertise. We've done a lot of those kind of projects on the side as well. So it's not very far removed from what we need to be doing.
If there are no more questions, yeah, one more question. Yeah, please, there. Can you please pass the mic?
Congratulations and good talk, sir. Sir, you were saying about that extended reality. So in this extended reality, can the haptics be combined with VR so that this VR, whichever had been shown, it's for skill training, will emphasize only the cognitive skills. So they have to touch the patient and they have to feel it. Yeah. So to feel that you have given the next option as haptics, can it be integrated and be given?
Yes, it can be integrated. I would say that currently the tech is not yet at a stage where it is viable enough to be integrated. It will take a couple of years in terms of where we can be with haptics. At the same time, whatever the visual learning thing, it cannot be a standalone be-all and end-all. Like we said, that's why we are hybridizing all the learning methodologies. The natural progression has to be towards bringing in as many technologies as possible. Haptics, I would say, if you look at the two types of haptics system that I showed, the gloves and the wearables, while they give you the haptics required in a more tactile sense or in between the two, predominantly one of the things we have noticed is at most of medical training involves the second type of system that I showed, which involves the force feedback mechanisms. Meaning it's not important how much you grasp, it's about like when you push, what's the resistance, irrespective of whatever you're doing. Putting in an IV line, you need to know where your needle is, right? That means again you're looking at different haptic hardware for different skills. So you're going to have certain hardware, but you will not be able to provide a single system which is scalable to a vast extent. So scalability focus will be on VR. The tactile learning aspects can be in haptic hardware, but the integration is done and it's happening. It's not a technical challenge.
Okay. Thank you, sir.
Thank you. If there are no more questions, I would like to thank Dr. Chinnaswamy for a very nice and interesting talk on new technologies. And let us give him a round of applause. Thank you.
Thank you.
Thank you.
Thank you, sir. I would like to request Dr. Sharif sir to felicitate our speaker.
Before we continue with our agenda, let us take a short tea break and come back for an interesting debate.
GSL Smart Lab is founded on the same core principles of GSL Education Society and providing world-class facilities to general public. As such, GSL Smart Lab provides basic training from anatomy to advanced laparoscopic procedures and robotic surgery.
Welcome to GSL Green Library, a sanctuary of knowledge and sustainability in the heart of Bharat. Nestled within our gigantic 50,000 square feet area, GSL Green Library is more than just a library. It's an oasis for learning and relaxation, designed to ignite your passion for reading. With a dedicated team of professional staff members, GSL Group is committed to providing the best possible support for your academic journey. GSL Green Library houses hundreds of copies of 31 subject book wings, ranging from medical, dental, physiotherapy, nursing to paramedical, alongside a general books lobby for your diverse interests. We understand the importance of creating a comfortable environment for our patrons. Our library is adorned with natural plants, relaxing chairs, and sofas, ensuring that your reading experience is not just enriching, but also relaxing.
This is just not a library, it's a library and much more. As you see around, you are reminded of Shantiniketan. But I would go a step still higher, and I would say this is just like the Shalimar Gardens that we have in Srinagar. Shalimar Gardens was a Mughal era structure. This is a 2023 structure. We have an all glass ensemble here, even the roof. So there is sunshine all over. When you talk of libraries or think of libraries, you know of dark, dingy cupboards with lights on even during midday. But here we have a facility where light is not required till the sun sets, and with so much of vitamin D flowing in, the idea is that the students who sit down here and study, they not only have a positive effect of the environment surrounding them, the green environment surrounding them, but so that what goes into their mind also is pure and green. If you are on the northern side, you can see the Eastern Ghats and the Korakonda Hill, and if you are on the southern side, you can see the vast expanse of the coconut fields and the cashew nut fields which are behind me. This is a truly green place where you can sit wherever you want. You want to see the lakes, you go to the south. You want to see the hills, you go and sit in the north. The idea is that the students of GSL institutions, they get the maximum out of their study time by sitting here.
And for students' convenience, GSL Green Library remains open 24/7, providing access to knowledge whenever you need it. In 24 hours, an average of over 400 students, medical researchers, doctors, and professors make use of this library. GSL Green
జనరల్ హాస్పిటల్, అగ్రికల్చరల్ ఫార్మ్, కార్పొరేట్ ఆఫీస్, ఒక CEO. ఇవి ఇలాంటివి ఎక్కడో ఒక చోట ఎప్పుడో ఒకప్పుడు మీరు చూసినవే. ఇప్పుడు ఇక్కడ మీరు చూసేవి కూడా అవే, అయినా కొత్తగా ఉంటాయి, ఒక క్యూరియాసిటీని తట్టిలేపుతాయి. టూ డైమెన్షన్, 3 డైమెన్షన్, 4th డైమెన్షన్ కూడా వచ్చేసింది. డాక్టర్ గన్ని భాస్కర్ రావు గారిని చూడడానికి ఈ కొలతలేవి చాలవు. 360 డిగ్రీల్లో ఆయన్ని చూసే ప్రయత్నం చేయవచ్చు. ఈ కొలతలో ఎవరు ఎంత చూడగలుగుతారో వారికి అంతే కనిపించడం డాక్టర్ గన్ని వ్యక్తిత్వ విశేషం. నిజానికి ఆయన చాలా సింపుల్ మనిషి. సింపుల్ సిటీ ఇంత కష్టమా అని కూడా ఆయనను దగ్గరగా ఫాలో అయ్యే వారికి అనిపిస్తుంటుంది. రాజకీయాల్లోకి రమ్మని పార్టీలు వెంటబడినప్పుడు నా రంగంలో ఉన్నత ప్రమాణాల సాధన మీద తప్ప పదవుల మీద ఆసక్తి లేదని వైద్య విద్యలకి అంకితమైపోయిన డాక్టర్ గన్ని అంటే ఒక నిబద్ధత. ప్రాణం నిలపడమే ముఖ్యం. మెడికో లీగల్ గొడవలు డాక్టర్లకు అప్రస్తుతం అని కోర్టుకెక్కి ఆ ప్రకారమే సుప్రీంకోర్టు ఉత్తర్వులు చేసేలా డాక్టర్ల స్వరాన్ని ఐక్యపరిచిన నాయకత్వం ఆయన సామర్థ్యాల్లో ఒక విశేషం. ఆపరేషన్ థియేటర్లో సర్జరీలు నేర్పించే సీనియర్ల కంటే అన్ని డైమెన్షన్లను చూపించే వర్చువల్ పాఠాలు, మెడికల్ సిమ్యులేషన్లు కొన్నేళ్లుగా ఇక్కడే ఉన్నాయి. దేశంలో పెద్ద పెద్ద మెడికల్ కాలేజీలలో కూడా లేని సిమ్యులేషన్ ల్యాబొరేటరీని నెలకొల్పి వర్చువల్ సర్జరీలతో మెడికోలకు ముందస్తు నైపుణ్యాన్ని ఇస్తున్న విజనరీ డాక్టర్ గన్ని. సుదీర్ఘమైన చరిత్ర గల మెడికల్ కాలేజీలో కూడా లేని క్యాన్సర్, రీప్రొడక్టివ్ మెడిసిన్ వంటి సూపర్ స్పెషాలిటీ కోర్సులు తీసుకువచ్చి మంచి వైద్యం చేయడమే కాదు, సూపర్ స్పెషాలిటీ డాక్టర్లను కూడా మనమే తయారు చేసుకోవాలన్న బాధ్యతను ముందుగా నెత్తికెత్తుకున్న వైద్యాచారుడు డాక్టర్ గన్ని. ఇది ఒకే ఒక్కడి వల్ల సాధ్యమైంది. అప్పట్లో ఆయన ఒక్క ట్రెండ్ సెటర్ కాదు, అంతకు మించి అని కాలం గడిచే కొద్దీ అర్థమవుతుంది. ఆయన ఒక గేమ్ చేంజర్. ఆయనే డాక్టర్ గన్ని భాస్కర్ రావు గారు. వారంలో చైనా 1000 పడకల కోవిడ్ హాస్పిటల్ కట్టేసింది. ఈ గేమ్ చేంజర్ ఐడియాతో రాత్రికి రాత్రే ఆంధ్రప్రదేశ్లో 17,000 బెడ్స్తో కోవిడ్ హాస్పిటల్స్ ఆవిర్భవించాయి. అన్ని ప్రైవేట్ మెడికల్ కాలేజీల టీచింగ్ హాస్పిటల్స్ ను కోవిడ్ హాస్పిటల్స్ గా మార్చాలన్న డాక్టర్ గన్ని సూచనను రాష్ట్ర ప్రభుత్వం వెంటనే ఆమోదించి దేశంలో చరిత్ర సృష్టించింది. నా ఆలోచన, నా సంకల్పం, నా శ్రమ, నా ఖర్చు, నా కష్టాలపై నువ్వు పెత్తనం చేస్తున్నావు. సరే, నాకు నువ్వు సగం సీట్లు ఇవ్వడమేంటి, నేనే నీకు సగం సీట్లు ఇచ్చాను, ఒప్పుకో అన్న గేమ్ చేంజర్ నినాదంలో నిజం మెడికల్ కాలేజీల పట్ల ప్రభుత్వ విధానాల్ని మార్చుకునేలా చేసింది. యోగా సాధనతో, యోగా బోధనతో మొదలయ్యే ఈ అసాధ్యుడి రోజు అరగంటకు ఒక టాస్క్గా బహుముఖ రూపాలుగా విస్తరిస్తుంది. పనులను సమన్వయం చేసే అడ్మినిస్ట్రేటర్ అవుతుంది, పురమాయింపులు చేసే నాయకుడవుతుంది, తీరిక చేసుకొని తోటకు వెళ్లి కష్టాన్ని తడుముకునే విశ్రాంతి అవుతుంది. ఆయనకు ఆయనే పోటీ. ఎప్పటికీ ఈ ఆట సాగిపోతూనే ఉంటుంది. డాక్టర్ గన్ని భాస్కర్ రావు గారు వర్క్ కల్చర్కు మీరొక రోల్ మోడల్, పని సంస్కృతికి మీరొక ఐకాన్.
would like to welcome all of the delegates and respected doctors for the debate.
వైద్యశాల ప్రారంభించి 20 ఏళ్లు పూర్తయిన సందర్భంగా జిఎస్ఎల్ అమ్మా భోజనం పథకాన్ని డాక్టర్ దత్తాత్రేయుడు ప్రారంభించారు. రోగులతో పాటు వారి వెంట వచ్చే వారికి కేవలం 10 రూపాయలకే భోజనం అందించడం పట్ల ఆయన హర్షం వ్యక్తం చేశారు.
అమ్మ భోజనం 10 రూపాయలకి పేషెంట్ రిలేటివ్స్కి వాళ్ళతో వచ్చిన అటెండెంట్స్కి వాళ్ళందరికీను ఇది చాలా అద్భుతమైన ప్రోగ్రాము. అది కూడా ఇనాగ్రేట్ చేసే అవకాశం నాకు దొరికింది, బ్లెస్సింగ్ అది. సో 10 రూపాయలకి భోజనం దొరకడం అనేది చాలా చాలా అద్భుతమైన విషయం. అది జనరల్గా చెప్పాలంటే ఏ ప్రజలకైనా సరే అన్నింటికన్నా ఉత్తమమైన దానం అన్నదానం. సో అన్నదానాన్ని ఒక జీవి అవతల
Welcome back, respected delegates and respected speakers. The integration of virtual reality into undergraduate education has sparked both excitement and concern. Please join me in extending a warm welcome to the speakers of upcoming debate with the topic Merits of Virtual Reality in Undergraduate Simulation Education. We have Dr. Adit Chinnaswamy sir, a renowned minimal access surgeon and the visionary co-founder of Medicine VR. And we have Dr. Dinkar Pai sir, Professor of Surgery and Director Medical Simulation Center at Sri Balaji Vidyapith, Puducherry, India.
We are honored to have Dr. Sri Seenu Vutaluru sir, Senior Professor of Surgery, All India Institute of Medical Sciences and founder of President of Medical Association for Simulation Training, Education and Research, Master, joining us virtually as the moderator of this debate.
Good morning. Can you hear me?
Yes,
Can
sir.
you hear me? Hello?
Yes,
Yeah.
sir, we can hear you.
So we have a very interesting debate on merits of virtual reality in undergraduate education, use of the VR simulations, and we have two speakers, Dr. Chinna and Dr. Dinkar Pai. First, I invite Dr. Chinnaswamy to speak on the motion. I think he is speaking for the motion, if I am right.
Yes.
Yeah. Dr. Chinnaswamy, please.
Great. We can. Okay.
Sir, can you see the screen shared as well?
Yeah, I can see it.
Great. Thank you, sir. I think, good morning, everyone. Once again, I'm back on stage. I'm going to bore you for another 15, 20 minutes. But we'll be deep diving into one of the particular segments that we touched upon during my previous talk about where exactly virtual reality can play a role in undergraduate medical simulation and whether it is called for. I'll be strongly arguing for the motion. Dinkapai sir will be mildly arguing against it. And to get us started off, I think we will skip this because you've all had a few talks about virtual reality and the depth of it. And when we are speaking about undergraduate utilization in medical education, I would refer to my entire talk previously as an argument for the proponent. I think we would say that there are multiple things that can be done with virtual reality. You can focus on skill training, virtual patients, and scenario-based training as well, in addition to the theoretical concepts. What we should now be focusing on are what are the benefits we get out of virtual reality here. One, we are able to standardize the training. Two, you get repeated practice. Three, the evaluation is very objective. Four, it has increased accessibility and flexibility. Fifth, it's going to optimize resources, not just for the user, but for the institution as well. So now let's go a little deeper into each of this. I think this is in follow-on to the discussion or the debate which Tilaka ma'am and Sandeep sir had as well. So one of the most commonly argued points was that there's no standardization of protocols in the current training universe. That is where virtual reality can make all the difference. One, any time that any student wants to learn anywhere across the country, they can be taught on the same consistent training protocols and theoretical information. There will not be any kind of bias based on who the instructor is and what are the protocols being taught. The next one, again, it provides a risk-free environment for learning, and you can practice complex procedures before you start interacting with the patient. The third one, I think virtual reality is now being considered as the gold standard for simulation, because the amount of immersive reality that it creates, no other technology can match, and which is why I believe that anytime you're looking at simulation and immersive training as a go-to norm, virtual reality has to be at the center of it. Second one, I think we touched upon repeated practice as well. So this becomes another cornerstone of learning for all of us, especially when you're looking at skill training. Practice makes perfect, right? And in the current generation of training, anytime you need to practice, there is so much dependency on material, learners, and instructors when you want to go through one experience. Can you go in at any time of the day and practice a skill and just get yourself familiarized again? That is not possible unless you have access to the catheters, the jelly tube, even if you want to do a catheterization scenario. You have limitless practice without there being wear and tear on the system. So that is a major disadvantage with the existing training systems. Of course, there are studies which say that there is long-term retention, which is better. I've shared the screenshot of that study as well. And finally, you can have your clinical reasoning skills also taught within the same experience. The next part I would come to is the assessment, and this I think is a very, very important part. Currently, it is mathematically and physically impossible to consistently keep assessing the students on all the required competencies. We resort to norms which are physically doable. But we know that that is not the gold standard even when utilizing the previous generation of training. For example, if we feel an individual trainer observing a trainee and then giving them a debriefing at the end of the session is the best way to train, is it possible for us to ensure that 250 students, 50 skills each, is that a doable task year on year for any number of trainers? Is this really where you want your faculty to be spending all your time? So that's why this creates a lot of difference. And of course, there are certain other solutions to this. There are workarounds in the existing methodologies. You would say peer-to-peer learning. There are values to that, but peer-to-peer learning can be for practice, but not so much for assessment when you want to ensure there are certain certified levels of competency for people stepping onto the field. Of course, I think the second and third points are well received by the students as well. Gamification of the learning process is entirely something which is the new rage, I would say. We find a lot of comfort and engagement with users when that happens. Yes, sorry. No, that's, you want to change the mic? All right. I think, hope you guys can, yeah, you can hear me better. I can hear myself better now too. Right, and moving on to resource optimization. One, now when you look at the infrastructure requirements, realistically setting up 10,000 square feet of space may not be a possibility for everyone, every institution. It again becomes a financial burden for institutions. Certain institutions may have the means to cope. Certain institutions will find it challenging. And that creates a perceived imbalance in the level of training that happens. So if you want to equalize the playing field, this is where technology comes in, and this is where virtual reality plays a phenomenal role. And then reduced instructor burdens. And I would say that this is where the faculty buy-in is the highest. We want to let surgeons be surgeons, anesthetists be anesthetists, and they do enjoy teaching proponents of their skill, but when it comes to having to spend time at the basics of education, sometimes repeatedly having to do that becomes a chore, and invariably there's a hit or a small down curve in the quality of the lectures being delivered. And then you have, this becomes cost effective as well, especially when you're looking at adapting it to scale. Currently, there are multiple studies which point out that you can achieve the same impact spending up to 70% lesser on virtual reality as a technology. The study states accurately that for every 30 cents you spend on virtual reality to achieve an outcome, you would have to spend $1.2 to achieve the same. And finally, of course, accessibility. One of the cornerstones of what virtual reality was meant to do was to actually enable remote collaboration and training. There is a major challenge here in logistics, in the medical professionals finding the required time to travel to distant places for their knowledge share. Here with virtual reality, people wearing headsets in any corner of the globe can all come into the same environment. Currently, we do that through Zoom. We think that is very acceptable, but even yesterday we were hearing points during the talks about it being a challenge to keep people engaged during Zoom calls. That is entirely taken off here. If it is virtual, the engagement drops unless you're physically present anywhere. So if there's a drop in engagement, there is subsequent drop in the learning outcomes as well. And then the third one is anytime access to learning. This is again a fundamental advantage, meaning since it is not dependent on a lot of external factors, you can walk in, I think in the evening at 6 o'clock, 7 o'clock. If you fancy learning at 12 o'clock, please be my guest. I think virtual reality can help there. Those are areas which other technologies will struggle. It puts a certain dependence on participation from the trainer as well, and which means the imbalance is on the trainer, on the trainee. The student has to learn when something is being taught. He cannot go and learn something whenever he wants to. I do my best studying, say, from 11 to 2 at night. That might be the case for a lot of you, but no one's actually going to come and teach you at that time. So that is where virtual reality and technologies like this can impact student life for the positive. And of course, exposure to rare cases and scenarios. Plethora of model, again, it ties into accessibility anytime, anywhere. Even the rarest of cases, you can have access to practice the same skill any number of times. I think there's been a huge upsurge of receptivity for these kind of technologies. The challenge always lies in the execution, and now we are able to show that there is, as long as it is adopted in the right manner, it fits a very particular particular problem, or it fills a particular void in the existing training system. It cannot function as the be-all and end-all, and that is probably not we are arguing here. But there is a definitive role that this technology can play, which other technologies will definitely fall short of. And with that, I'll rest my case and hand it over to Professor Dinkapai, and we'll take it from there.
Thank you, Dr. Chinnaswamy. Now I invite Dr. Pai to make his presentation. And I want to warn Dr. Chinnaswamy that don't underestimate the mild response of Dr. Dinkar Pai. Ask the residents or the undergraduates of JIPMER, and they will tell you. So be prepared. Fasten your seat belts for the next 20 minutes. Dr. Dinkar Pai, please.
I'm not supposed to use this. Okay. This one. Can you hear me, Prof. Sinu? Thank you for making me the victor of this debate before this debate even started. That is the sort of moderator I want, who's totally biased towards one side. And I know Adit has spent quite some time talking about the benefits of VR. And before I start, a disclaimer. I am a consultant with Adit's company to help them develop VR. And so what I'm talking about here is only in the context of this debate. So I just want to give that as a disclaimer to start with. Then coming to, he spent a long time trying to convince you about the benefits of VR. It's my belief that the longer somebody speaks, the more unsure they are of their point and about themselves. So I will try to just refute some of the things. I don't need to give my own talk. I can just go based upon what he said and refute it immediately, but I'll save it for the rebuttal. So when we are talking about VR simulation, are we looking at the world through rose-tinted glasses than the world is actually, what the world actually is? I'll quickly go through this since this may not be familiar to the audience. I think Adit has already talked about it. So now we have reality, which all of us know. Augmented reality, where majority of the world is real, and you see these few figures of the dogs and all that which are generated in the VR environment. So this is augmented reality. The next level of virtualism is the augmented virtuality, where only the dog and the duck are real. The entire environment is VR generated. So the difference between augmented reality and augmented virtuality is how much of the environment is real and how much of it is virtual. And we have full virtuality, where everything is virtual. So I'm going to be confining my talk to that full virtuality segment. And somebody was asking about extended and mixed reality, and that is mentioned on top. So once you include full virtuality, we are talking about extended reality. Now, how real is VR is the question that I would like to ask Dr. Adit. We are talking about virtual reality. I don't like the fact that the word virtual has been put in front of the reality. That itself shows that it is not real. Okay? VR is not very real. Why is VR not very real? Because there are limited boundaries for the VR environment. If you have used a VR headset, you take 2 steps in any direction, you come up against a green screen which tells you, hey, there's danger here, don't cross this, right? So you have a very limited real environment in which you can mimic that VR. You have poor design of virtual objects. Again, all of us who have used virtual reality will be the first to attest that the virtual objects in the virtual environment do not look exactly like what they would in the real world. And the image resolution is poor. Adit will try to convince you, no, technology is improving and all that. I will tell Adit we'll have this debate in 5 years' time when the technology has improved. As of today, the image resolution in most of the VR headsets is poor, and that leads to issues like headaches, etc. We have issues with simulation accuracy. how accurately are your actions depicted in the VR world. If your alignment and etc. is not correct in the VR world, sometimes you can end up with a totally mismatch between your patient is there and you're doing the catheterization over here, or your patient is sunk into the floor, or the patient is up there, you know, and you are down here. So there's a lot of alignment issues in VR. Anybody who has used VR can attest to that. And of course, there is practically no physical realism in a VR environment. And that includes, somebody was mentioning in the audience earlier, haptics. And Adit has himself confessed, thanks Adit for confessing that haptics is yet to come in a proper way in VR. Okay, is it worth achieving reality in VR is the next question I would ask. First of all, we have said that VR, there is a lot of issue with realism. Next is it really worth achieving this? This is a very interesting concept. I don't know how many of you are familiar with this. It's called the uncanny valley hypothesis. And this was postulated as far back as 1970 by Masahiro Mori in his book, Bukimi no Tani, in which he argued that if you look at the emotional reaction of human beings to artificial environments, as you are approaching closer to reality, you start liking it more and more, but then there is a sudden dip when you are very close to reality but not actually realistic. There's a sudden emotional negativity that we experience, and that is what he called as the uncanny valley hypothesis. And if you see in this graph, the laser not working. If you see in this graph, as you go, on the x-axis is the emotions and the affinities on the y-axis, sorry, and the realism is on the x-axis. As you are going from left to right, you see that the affinity or the positive emotional response of human beings keeps increasing until you reach just short of total realism, when there is a sudden drop, because what you see is almost realistic, but it's not actually real. And there it leads to a conflict of senses for us. For example, if you're looking at zombies, they are very realistic, but not quite real. You see their faces are distorted, you have those issues, and we have a very negative connotation with those zombies, or a corpse for that matter. And then finally you reach the actual realism, where again you get the affinity. So it's very important to understand that right now in VR, we are in this uncanny valley hypothesis, where we are deep in the valley and it's going to take a lot of effort for us to climb out of this valley. You can see this picture here. This is from the famous movie Polar Bear. And it is one of the classic movies which is quoted all the time when we are talking about uncanny valley hypothesis. A lot of negative emotional connotations were there from people who watched this movie, because you see this was all virtual reality creating these human-like people, but the faces were not exactly human. So they had a lot of negative reactions when they saw this. And this is one of the things that is commonly quoted for the uncanny valley hypothesis. What happened? Stuck? Okay. Next, we talk about the issues of cyber security, data privacy. VR environment is ultimately a cloud-based environment, and all the limitations that we have of cloud-based environments would also apply in VR. So you can have data leaks, you can have cyber security leaks. You know, right now it's only your credit card that is leaked and your photographs are leaked. Now your avatars will be started to leak once you are in the VR environment. So you'll have somebody representing you in a three-dimensional form, and entering your home, and your wife thinks it is you, and then all sorts of problems will happen. So holograms are coming in. So we have to be very, very careful about this. Okay, let's talk about pedagogy. Let's talk about educational value of VR. There is limited interpersonal skills training, because we cannot really replicate the complexity of human interactions when we are talking about ER. And this is essential for patient care. Looking at an avatar of a doctor for a patient is not the same as looking at the actual doctor over there, right? Integration with other training modalities. I talked about that synchronization, especially when we are talking about augmented reality. The augmented image has to sync very well with the real image. And that lack of syncing can cause issues. And you can't predict high pressure situations found in real healthcare settings, especially in an emergency department or in an OT when the patient is bleeding all over the place. There is no way a VR environment can replicate that tension, that excitement, that the anxiety that is caused in such a situation. So there's a disconnection from a real world experience. And of course,
the learning curve, Adit again has made my job easier by confessing that it's very difficult for faculty to learn this particular thing. And so it's a long learning curve for learning these technologies. Okay, what about finance? Cost and accessibility. Adit says, oh, it's much cheaper. Anybody who's really bought a VR headset will know what he's talking about is nonsense. Okay, cost and accessibility is, I'm borrowing a page from Tilaka's world page over here from her debate yesterday. It is not accessible. How many institutions today have VR accessible to them? How many of them are already on the bandwagon? So when you have resource constrained organizations, that becomes an issue. And of course, technical complexity. Adit, every institution where he has sold his product, he employs a technical person to stay in that institute. Why? Because that institute will not be able to take care of that system if that person is not there, right? So this is the technological complexity that we are talking about. Okay, what about assessment? There are no validated assessment tools in VR. Okay, whatever validated assessment tools are there for non-technical skills, they are not validated for VR simulation. Assessment metrics for the skills are not validated, and most of the studies are set up to assess a simulation or a scenario, and they reach only Kirkpatrick level 1. Maybe with some great difficulty, it may reach, through a lot of straining, it may reach up to Kirkpatrick level 2, but not beyond that. Some papers that I just want to draw your attention to. This is one paper which was a systematic review on virtual reality simulation in non-technical skills for health professionals. And what they said was that very few medical specialties use virtual reality for non-technical skills training. And it concludes, more importantly, that the evaluation of VR systems as training tools is essential, but there has so far been very little systemic research. So Adit, when he's talking about VR, he's talking in a totally virtual world. This is the real world situation. Another paper which was published, creating a successful virtual reality based medical simulation environment. Sounds very positive, isn't it? So they talked about this acronym, which is what you should be ticking off whenever you are building a VR system. They call it build reality. Build stands for beginning the process, using the needs assessment to set the objectives, identifying the best virtual reality modality, leveraging and building content on that, and then defining and to support the VR environment. And the reality stands for recreate accessibility within the VR environment, and then educate users, adapt and test the VR environment, look for VR simulation champions, identify barriers, test the impact of the VR tool, and for some reason amplify VR in the 21st century. They put it as a Y. Okay, so this is the build reality tool, and my point I'm trying to make over here is, if you look at this tool, most of this we have not yet achieved when we are talking about VR. So in conclusion, I would like to say that our virtual reality has only just begun. We are not yet ready for this technology, and tried and tested methods work best. If it ain't broke, don't fix it. Thank you very much.
Thank you, Dr. Pai. See, in North India, there is a word like, if you want to set right somebody, there's something called ki isko na rajai mein lapet ke peetna. That means that you cover him nicely with a warm blanket and then just hit him so that he doesn't even feel that he has been hit, and he still has been hit. So now I request Dr. to give the rebuttal. You can take about 2 minutes for the rebuttal. Dr. Chinnaswamy, please.
Thank you, sir. I think that was the same presentation sir probably made when laptops or iPads were first introduced, or maybe mobile phones were first introduced, and he probably just copy-pasted some of the things from the mobile phones and then switched it out to virtual reality. I think but that is the essential curve that goes through when any technology comes into play. A lot of whatever he did mention, in terms of alignment, those are all things I would say that happen when you are not yet familiar with the technology. Even now with your phone, you open up your phone and you don't know where the switch off button is, you can't switch it off. You're not going to be able to operate any technology if you don't put in that minimal effort which is required. And I would say a 15-20 minute learning curve is not that bad or that challenging. And more than anything, the necessity for having to have an operator at the labs, as sir mentioned, is to safeguard our equipment and make sure that it's used properly, rather than people trying to learn and practice on our equipment and causing damage to that. So that is something which happens in the infancy of any this thing. I'm sure you remember, I'm sure sir particularly remembers when computer labs became the first, became the norm in institutions. I'm not that young. I also remember when computer labs first came into institutions as well. It was very, very heavily policed, right? You would have for even 2 or 3 computers, there would be 3-4 people making sure, hey, don't tap the keyboard too hard, right? That is all like that, the initial tech cycles wherever we go with. In terms of visual disturbances, something which sir did point out, I would say that is again some thing which was taken from a very, very early stage. Things have changed now. We are able to watch 2-hour movies. Of course, there's going to be a small adaptation curve in terms of your eyes resting, but industrial studies have proven that you can watch entire movies in virtual reality headsets without having any long-term effects. And it was a very good point about the uncanny valley. That just shows us how we have to utilize the technology, not that the technology is bad. You stop at a particular place, don't try to imitate reality in its extent. You know that this is a virtual environment, but you're still getting a better learning outcome out of it. So I would say that is one area which I wanted to point out. And I'm sure no one liked the polar bear movies. The script was also very bad for it. And of course, cybersecurity, that's something, anything to do with the virtual world, that really doesn't even apply to this debate. Sir has been very clever in interjecting certain issues into the topic which make no relevance, so I'm just going to brush it off altogether. Sure, pedagogical issues, the learning curve, yes. Even we had a workshop where sir was training about a lot of faculty on how to integrate hybrid in VR utilization. And they were exploring the utilization of patents method. Patents was derived, all existing training principles have been derived on what was the technology available at that point. Books are a form of technology. Computers are a form of technology. So are mannequins. So previous principles have all been derived based on previously existing technologies. And sure, it may not apply to pedagogy, but we may come up with the next learning principle which might have better learning outcomes. And that is where I think time has to be spent when it comes to the technology. And of course, even the study which sir pointed out, it really said that VR training is essential, but systems have to be put in. I think that speaks for itself in terms of how virtual reality can be adopted. I'm going to probably rest my case here and let sir, I think, hear from Sinu sir.
Dr. Chinnaswamy, thank you very much. There is a saying in English called as appearance can be deceptive. You look so slim and you are so soft-spoken. So, but your rebuttal will, I think, startle and unsettle even the most accomplished Dinkar Pai. Dr. Pai, your rebuttal, please.
Sir, I have one request for you. Kindly allow me about half an hour for the rebuttal, because there are so many nonsense that he has spewed. It will take me that much time to rebut everything that is said.
I think this goes back to you saying the longer someone has to speak, the plot has been lost.
Okay.
Yeah.
So he was talking about my using copy-paste and my talk. Almost everything he talked about VR was copy-paste from simulation. I am a firm believer in simulation, but whether you talk about gamification, whether you talk about immersion, whether you talk about whatever the pedagogy and everything else he talked about in VR is basically simulation. He has copy-pasted everything that is talked about in simulation and very cleverly converted it into his talk. You have finished, now it's my turn.
Yeah, this is not fair, but okay.
And he very cleverly put it into VR, okay? Number one. Number two, he is talking about things like long-term retention. He's produced evidence, fantastic evidence for long-term retention in the form of one paper in 2024.
I have a rebuttal for you. Demetrios et al. In the journal Surgery, they compared video training versus virtual reality in laparoscopic simulation training, and they found that video training was better for long-term skill retention than virtual reality. Okay, I'll refer that paper to you. So just because you quoted one paper, I'm quoting one paper back at you. So that takes care of your long-term retention nonsense. Coming to gamification you were talking about, we had a beautiful workshop with Mahalakshmi. I'm sure she will support me, even though she has been supporting you throughout this quiz, as I saw. We did gamification workshop without any element of VR, and whoever attended that workshop will agree it was a very successful workshop, right? Raise of hands, come on. There you go. Okay.
Sir, this is intimidation, agreement by intimidation.
Okay. And what else do I have to say? Yeah, you're talking about the cost. All the cost that you're talking about is in Western concepts, like so many dollars. You understand that labor is very, very cost intensive in Western concepts. Here in India, it is not the same. So if you were to take equivalent cost of the labor of hiring somebody versus the cost of VR, you will find a huge difference. Technology is expensive in India, labor is cheap. It's opposite of what is there in the Western societies. So I don't think that applies over here. So I think, I mean, I could go on and on and on, but I'm feeling sorry for others, so I'll stop over here. Thank you.
Thank you, Dr. Pai. So what does the House think? Like, should VR be, is going to stay as a part of simulation education?
And we have a show of hands from the audience, please. Those who think this fellow has won, raise your hands.
No, Dr. Pai, don't intimidate.
No, okay, sorry, I
should down. Who feels that VR is here to stay in simulation? Please raise your hands.
Cool.
Who feel that it is still time to take for VR to be a part and parcel of simulation? Please raise your hands.
I see the same hands being raised for both the points.
Sir, one
Same people raising hands.
I would like to add one more thing. Sir correctly pointed out that a lot of whatever I said in VR was copy-pasted from simulation. I think that just goes to prove my point and his point exactly.
So let me sum up the debate. And what is very certain now or established that simulation is going to be a part of training, whether it is undergraduate education, whether it is postgraduate education or a fellowship training. That there is no doubt.
Dr. Sinu, I'm sorry to interrupt. There were some questions. Would you allow questions from the audience or comments from the audience?
Yeah, please. Yeah. Sure.
Yeah, Avinash Supe is there.
I
he wants to
can't see
say
them.
something.
No, right.
Sinu, nice to see you here. I think this was a really typical Andhra chili spicy debate, which we really enjoyed. But I think, VR is anyway going to come. Now, let me ask you, do you use HD TV at your home or you still use the old TV?
Absolutely HD TV.
So now I think when HD TV came, everybody started saying the same thing. It is not going to come in India about 10 years ago. And also if you really look at the history of innovations, even when the ink came, ball pen came, computers came, everybody has really said no. I think it's a question of time. Maybe not now, but in next 2-3 years, VR is anyway going to come. I don't think it's, I think so we should accept it that VR is a reality rather than virtual reality.
Sir, I have exactly poles opposite, but agreeing with it. Everyone said 3D TVs, curved TV is going to be the future. Where are they? Where are those products at the minute?
Correct. HoloLens is going out.
I thought the debate is between Dr. Supe. The debate.
Adit, I'm going to support your case. I just want to quote the 3 laws of technology which were given by Arthur C. Clarke. He's a science fiction writer. Okay. The first law is when a distinguished but elderly scientist, I'll substitute it with professor, okay, states that something is possible, he's almost certainly right. Okay. And when he states that something is impossible, he's very probably wrong. And any sufficiently advanced technology is indistinguishable from magic. So that's what is going to happen soon with VR also. Adit, you owe me one.
Tilaka, you want to say something?
Yeah, first, ma'am, definitely.
Tilaka?
So I would like to clarify my
you want to
point.
say
I never
something?
said that VR is impossible. I was talking about VR as it stands today.
Sir, let's
Lekha, you
face
want
it,
to
you
say
are hurt
something?
by elderly comment.
As you said, it's currently today. I think that's the topic of the debate is for undergraduate. So I think most of the hands which was raised by the undergraduate, that shows that today that VR is in capacity. Whatever we were talking, I think we are talking from our point of view. If we check it out from their point of view, I think today VR is on the process. Thank you.
Absolutely. I think we are very guilty of training students only in the way we want to train them, not in the way they want to be trained. I think that's why VR flips the script. Yeah.
I think Dr. Supe has put it very well. Like, simulation is here to stay, and VR as a part of simulation is here to stay. I think that should be the summary of this debate. So, if the organizers permit, we can end this debate at this stage, accepting that VR is going to be a part and parcel of simulation training. Thank you, Dr. Pai. Thank you, Dr. Chinnaswamy, for the nice debate.
Thank you, sir. And I would like to place on record over here that I admit that I have lost the debate to Aditya.
Thank you, sir.
I know you should.
Thank you, sir.
Thank you.
Thank you so much, sir. Coming up is a talk on virtual reality in anatomy. I'd like to invite Dr. Lavanya ma'am, Professor of Community Medicine, GSL Medical College, to come and introduce the speaker of the session. Is a talk on
introduce a highly esteemed figure in the field of medical science, Dr. Ahmadullah Sharif. Dr. Sharif is currently working as professor and HOD in the Department of Anatomy at All India Institute of Medical Sciences, New Delhi. With a medical career spanning several decades, he has made significant contributions to both medical education and research. Dr. Sharif obtained his MBBS and MS degree from Jipmer, Pondicherry in 1986 and 1989 respectively. He has since established himself as a pioneering researcher, particularly in the areas of clinical ecotoxicology, heavy metal toxicity, and development and plasticity of the enteric nervous system. His work has led to the establishment of numerous state-of-the-art facilities at AIIMS, including the first clinical ecotoxicology research and diagnostic facility in the country. Among his many accomplishments, Dr. Sharif has standardized histological processing techniques, established neural tissue culture laboratories, and developed digital image analysis labs. His innovative research on fluoride toxicity and heavy metals has earned him national and international recognition. Dr. Sharif's dedication to advancing medical science is further exemplified by his role in developing e-learning resources and implementing a learning management system at AIIMS. His research has been widely published, and he continues to mentor the next generation of medical professionals. He has a number of accolades to himself, but due to, I'm just introducing him with few of them. Welcome you, sir. The floor is...
Thank the organizers of this conference for giving me this opportunity to share my thoughts on virtual reality in anatomy. And I also want to thank the organizers for the excellent hospitality they have provided me and my family. Thank you so much. And it's a privilege to be here and talk about the virtual reality in anatomy. So at the outset, one disclaimer. At AIMS, we do not yet have any virtual reality setup. It's not because we are against virtual reality, but because we have the best resource for learning anatomy, that is the cadavers. We do not have a dearth of cadavers, and there is nothing better than doing actual dissection of the cadaver to learn anatomy. So we till now feel that the virtual reality is not yet there, and we are waiting. We will adopt it when it is ripe enough. Okay. So with that, we have been doing some elementary work in improving the virtual reality resources, and we are working with some companies to make the virtual reality better in anatomy. So with that disclaimer, I would like to share my thoughts on virtual reality, and I should thank Professor Avinash Supe and Aditya for having set the stage, and they have showed everything that needed to be shown on virtual reality and surgical training and everything. So it is not necessary for me. And I take this opportunity to thank both of you for having set the stage where I can talk at a more humble level and go into a little bit of history of the development of virtual reality in anatomy. So all of us agree that COVID has been horrible, and probably the only silver lining in that dark cloud was the rise of digital technologies and online meetings and work from homes and all those things. So probably we can give the due credit to this horrible pandemic. So, and the shortage of cadavers in many institutions is what is prompting the adaptation of the virtual reality, though it is not mature enough, but something is better than nothing. So I think we should encourage those institutions and the virtual reality providers to go ahead and continue doing what they have been doing and make efforts to improve that. And then there are ethical issues of cadaver supply. At least in some of these Middle Eastern countries, the cadaveric dissections and donations are not permitted. So in those scenarios, it may be good to adopt the virtual realities. And cost and limitations of physical dissection laboratories, the dissection halls. So maybe preventing some of those institutions to have elaborate cadaveric dissection facilities. So they may be going in for the virtual reality models. And as Aditya has already pointed out, that this is easily accessible anytime, anywhere learning. So these are some of the factors which have given rise to the digital anatomy, and virtual reality is probably the ultimate form of digital anatomy. So I think enough has been said to define the virtual reality, augmented reality, and extended reality. So I'll be just skipping those to keep my talk short. So augmented reality overlays, as Dr. Supe and Dr. Chinnaswamy have pointed out. So Google Lens, Google Translate, and other applications use augmented reality. And then there is mixed reality, which combines AR and VR. So I think enough has been said about all these different realities which are actually not real. At this point, I would like to acknowledge the seeds that have been sown for the development of digital resources and the virtual reality as we know. I think we have to give due credit to the Visible Human project, which was actually planned in the late 80s, and it fructified by about 2000, starting from 93, 94 onwards. So this Visible Human project, I would like to share some of the facts about this Visible Human project for the younger generations. I think some of the people of my generation may be knowing about this project, and it is necessary for the younger generations to know a little bit of history of how and when the seeds have been sown for the development of virtual reality. So this Visible Human project was to capture the cross-sectional photographs, okay? Photographs to facilitate anatomy visualization applications. So the cross-sections in many of the VR applications that you have seen, which are of low fidelity, are coming from the imaging modalities like CT and MRI. But this was the real anatomical cross-sections, which are full color and which actually reflect the real texture of various organs. And Michael J. Ackerman was the director of this project at the US National Library of Medicine, the NLM, Bethesda, Maryland. So this planning started in 1986 and it is completed in 1994. They had more than 1,800 cross sections which are photographed in analog as well as digital. That was a good decision because the digital imaging was not very well developed at that point of time. You know, for you it is very common to have a 25 megapixel camera in the phone. At that time, that kind of resolution was not available even in US. So they have done well to go for analog images of 70 mm film, not just 35 mm. So I think they have very high resolution analog photographs of that. And because they had that, they have re-scanned those images again in 2000 at a higher resolution. So initially they scanned those at a lower resolution. And the female cadaver cross-sectional anatomy images were completed in 1995. And we will see some of the details of these details and differences between the male and female cross-sectional images in the Visible Human project. And all these images are now freely downloadable from this website of the National Library of Medicine. All of you can easily download. When I downloaded these images in the 90s, early 90s, I had to sign a license agreement with Michael J. Ackerman, which was duly forwarded by my head of the institute. That is, the director of AIMS had to forward that. Now they have made these images freely available, and many of you who are interested in experimenting with the development of virtual reality applications for anatomy may like to download these things, because these are high fidelity real photographs of cross-sectional anatomy, and they are not models, 3D models or surface models created by the many VR applications right now. So Visible Human male was a donor, Joseph Paul Jernigan, who is a 39-year-old Texas murderer executed by lethal injection on August 5th, 1993. And he has agreed to donate his body before he was executed because of a suggestion of a priest who met him in the jail. But he was not aware that his body was going to be used for Visible Human project, and because of that many people raised some ethical questions and they are not using these images. So it is up to you to take the call whether to use those images or not. And they have done MRI and CT before the sectional anatomy images were cut, and head and neck they have taken axial images, and rest of the body are longitudinal MRI images, and at 4 mm intervals, and they were 256 by 256 pixels and 12-bit grayscale. And CT data was again axial scans of the entire body at 1 millimeter thickness and 512 by 512 pixels in a 12-bit grayscale. So the anatomical images, the analog images are captured on a 70 mm film, and digital images are captured in 2048 by 1216 pixels in a 24-bit RGB color, and each pixel size was 0.33 mm, but the sections were 1 mm. So the pixels, if we consider the voxels, they are not cubic, which they have corrected when they captured the female cross-sectional images, photographic images. And the analog pictures were rescanned at 4096 by 2700 pixels in August 2000. So after that, these high-resolution images have been made available, and many of the virtual reality applications which were developed soon after have been inspired by this project, and many of them have actually used these images for developing that. And Voxel Man, which has also been quoted in the Gray's Anatomy, is one such application in Germany. And I think that is also freely available for download. So visible human female had the same features, except that the slice thickness was reduced to 0.3 mm instead of 1 mm. So that makes the voxels cubic, and it will make the volumetric renderings more accurate and distortion free. So there are 5,189 anatomical images of the female. And this was a 59-year-old anonymous donor described as a Maryland housewife who died from a heart attack. And CT MRI characteristics are same as that of the male, except that the slice thickness, if we can call it so, is 0.3 mm, which makes the voxels cubic. And Voxel Man was one of the applications which was developed early in Germany, using this visible human data set. So this is a kind of a volumetric rendering, and you can arbitrarily cut in any planes and you can see the cross sections. So that is the difference between the current virtual reality applications, where the organs are surface rendered, and if you cut them they will be hollow. Whereas in Voxel Man, if you cut, you can see the internals of the organs. Some other VR applications which were using the visible human data set are this virtual human, which is a collaborative project between Argonne National Laboratory and the University of Chicago. Vesalius project, which is a computer-based anatomy curriculum by Columbia University, and computer graphics and medicine by Mira Lab at the University of Geneva, and some other explorable human, virtual human by Center for Human Simulation at University of Colorado. So Voxel Man was quite notable, and they are one of the earliest teams that have used the visible human data set, and I think I am yet to see a similar virtual reality application which has volumetric data in it. I think the developers in virtual reality may think of working in that direction. So what are the various steps? Just for the uninitiated, because most of you already know how to create virtual reality applications. One is data collection. So I think we have seen the best method of data collection for developing virtual reality applications in anatomy may be the photographic data of the real cadaver sections. Otherwise, DICOM images of CT and MRI can be used, and segmentation is the crucial step in the creation of virtual reality, because that will decide the fidelity. That is, how much detail are you willing to give in your structural, the structure of the organs or the body. Which are the fine nerves that you want to demarcate. So I think segmentation is the key process. Probably a lot of anatomists will be required to work on this aspect, and probably in future, the AI-based programs and machine learning may be trained to, annotate more detailed structures in anatomical images. 3D reconstruction, model creation, and surface mesh, and detailing of the surfaces to add textures and colors, that is another step, and refinement of the mesh for optimization to the kind of hardware, because if this mesh is highly detailed, it will require more sophisticated computational resources to deal with the data. So there is some kind of optimization required. And integration into virtual reality platforms, like Dr. Aditya was pointing out, gamification. It is, till now, it is the gaming engines that are being used for creation of these virtual reality models and environments. So Unreal and Unity are such engines. And then we will have to add interactivity, like tools for zooming, rotation, and arbitrary cuts and all those things. So all these things have to be added. And these are the various steps, in a hand-wavy way of discussing about development of virtual reality. And earlier days, when such computational resources were not easily available, very early, in the late 80s or something, Apple has come up with a kind of a pseudo virtual reality that was called the QuickTime virtual reality. And we can say that this was a quick, these models were created by taking a lot of photographs. After keeping all those images were stitched into an object, and that is played like a movie, and this was called the QuickTime virtual reality by Apple. And this was quite common, and we also used to play with this kind of virtual reality models. And you already have these virtual dissection tables. And I think Anatomage uses the Visible Human Project dataset. I'm not sure about Sectra, if that is also using that. And Google has created what is known as Google Body, and which is now called the Zygote Body. And this is freely available. Yeah, I just got the news that the previous dissection tables, Anatomage and Sectra, I think are already available in this hall, and those of you who have not seen that can go and have a look. Thank you. So this Google Body, or the Zygote Body, is a web-based application which can be seen in the browser, and you can actually peel off the layers from the muscle tissue down to blood vessels, and they can be removed and they can be made transparent to see the deeper structures. So most of the body parts are labeled, and they are also searchable. And this is one of the Google applications, and it looks quite high fidelity. And then there are other publishers who have the virtual reality anatomy learning resources. And this is complete anatomy from Elsevier. And then there is an anatomy 3D atlas. And there is another application called 3D Organon and Human Anatomy VR. And then there is also another Irusu Human Anatomy 4D. Again, this is a kind of an augmented reality where you can have holographic images floating in the room that you are there. And there are other applications which need the headset. And these are those XR Anatomy by Walters Kluwer, and on the left, and on the right, that is by BioDigital. And you can interact. I think Dr. Chinnaswamy, Dr. Aditya has already demonstrated these applications. So that is the direction in which the virtual anatomy applications are. All the students of anatomy and the faculty will know that this is how the cadavers look. And this medical holodeck dissection master XR actually uses the real dissections, and they have scanned at very high resolution. And as an anatomist, I tend to like these because they have better fidelity and more details as they are scanning the real human cadaveric dissections. So I think this is actually more closer to cadaveric dissections compared to other virtual reality applications, which have been 3D models which have been created using surface renderings. So this is what is the state of art in teaching learning of anatomy using virtual reality tools. And what are the issues? I think the debate just before my talk has highlighted the issues with virtual anatomy. The same thing here, cognitive load. You know, when a teacher is teaching the students, he actually concentrates on something. You know, there is a direction and there is a way to go about navigate through the data that is hitting the senses of the student. But here in virtual reality, there may be overload of information to the student, and cyber sickness, Dr. Supe has already pointed out. And the biggest thing is lack of tactile feedback. I think we don't learn just by seeing something. We also learn by touching, pulling, cutting, stretching, all these things. All these things are lacking in virtual reality. I think we should not underestimate the contribution of all the other senses in learning, because the more senses get stimulated while we are learning, the more longer the learning is retained. And for understanding the relationships, it is important for us to actually lift up, pull some structure, and pull something away and see what is deeper to something and what is passing through something. Okay, so I think those are not easily explainable or easily demonstrated in the virtual anatomy models. And the technical limitations are significant computational power is required, though the cell phones that we are carrying in our pockets today may be similar in computational power to the supercomputers of yesteryears. So, but still, I think the more powerful the hardware becomes, the more we start demanding, because the kind of data that needs to be processed is enormous nowadays. And you have seen that the resolution is not really acceptable, at least not for an anatomist. That is, I would not be happy with the surgical models that are being shown for surgical demonstrations of whatever, laparoscopic surgeries or those things. As an anatomist, that kind of resolution is not acceptable to us. And as there is always user resistance to adoption of the technologies, and interactivity and realism is lacking because of lack of haptic feedbacks, and you cannot know the consistency, whether a structure is soft or hard or stretchable or friable. All these things are not there in virtual reality models now. Probably a lot of research is going on now, and that is probably it will take some more time for those things to be incorporated. The haptics and the textures. As pointed out, the cost will ultimately come down. So these are some of the issues. And what is the future of VR in anatomy? Integration with AI and ML. AI and ML seems to be there everywhere now, starting from washing machines to rockets that are being launched by Elon Musk. So anatomy is no exception. So how do we think that AI helps anatomy? So right now, we can ask AI to write an essay on, let us say, kidneys. And probably it may write. But then, unless you know anatomy, you can't actually trust it. And if you already know anatomy, and then you don't require AI to do, at least as the AI is able to do right now. And machine learning probably may help us in segmentation, better segmentation, because it is a tedious process. Segmentation means isolation and identification of various fine structures in the human body. And Internet of digital twins, I think Dr. Pai and Dr. Chinnaswamy have pointed out that digital twins will be created, that is digital representation of a complete patient, including all the data which is coming in through all the sensors and everything. That is physiological processes and even biochemical processes may be integrated in the digital twin, and then that digital twin can be used for various diagnostic and therapeutic purposes. And security of the data, anatomical, physiological, and all this data may be better ensured by use of technologies like blockchain and metaverse integration. And enhancement of interactivity and haptics is something that a lot of teams are working on right now. And remote and collaborative learning is possible because the students and the teachers need not be at the same place, and the groups of students can learn topics together. So all these are possible now with very fast communications like the 5G data networks. And obviously, as the popularity of the technology increases, the cost and accessibility issues will be addressed. So this is, for example, an AI-generated anatomy image. How do we rate this image? Artistically? Out of 10, how much would you give? 8, 7, whatever. Some marks we can give for the artistic accuracy. What about the anatomical accuracy? Out of 10, how much will you give? 0. Okay, so artificial intelligence is a great artist and not a great anatomist yet. So let us wait for it to learn anatomy. Okay, with that, I end my discussion of virtual reality in anatomy. So I am neither for nor against the virtual reality in anatomy. I am waiting. Thank you. If there are any questions, I would like to answer. Mike.
Thank you, Dr. Sharif. That was a wonderful talk. I just wanted your take as an experienced anatomy educator on how these newer technologies fare vis-a-vis the standard physical cadaveric dissection. Would you say that this is an addendum to the cadaveric dissection that's already going on? Or do you believe that we can do away with cadaveric completely and do anatomy training only with these newer technologies?
Yeah, thank you. Nice question, I think. There was also some question whether the anatomists will be replaced by AI, whether anatomists are going to lose their jobs. Okay. Now, if I say that to Dr. Pai's question, if I say that it is going to replace, then I will be out of job. Yeah, I think our job description is going to change. And I don't think the cadaveric dissection can be dispensed with. Whenever possible, if you have a cadaver, that is the best way to learn anatomy, and there is no doubt about that. And all other tools will be supplements. Probably a student will get the opportunity to dissect a cadaver once in a lifetime. But rest of the time, he will be using this simulation and all virtual reality technologies to refresh their knowledge of anatomy. And some concepts and some difficult areas may require repeated refreshment of the knowledge, and that is where the virtual reality and all the other tools will come in. It is like if you ask somebody which is the best way to swim without going to the pool, I think you get the answer.
Sir, I have exactly opposite take. The reason why they are clapping is because they have helped us conduct boot camps. And we started entire anatomy, dissection and virtual interface as the first step of boot camp for surgical trainees. What's your take on it?
Yes, you can use it as a first step. It is like giving a brief overview of something. It is like in our dissection hall, we use videos and whatever digital resources we have before the dissection to tell the students what they are expected to do using the cadavers. And that can be a very good source before doing dissection and after doing dissection, but not a substitute for dissection. Yeah.
Any more questions from the audience?
So thank you so much, sir. I've always been extremely amazed at how you so seamlessly adapt to technology, always in all fields, right from my post-graduation days I've been seeing you. So I just wanted to add one more thing that you were, to what you were talking about. Will anatomists be replaced? Of course, there is a lot of talk, but it can never happen because so resources are something that is going to be available. Today, I don't think there is any field where the resource dearth is there at all. But I feel facilitators only help them understand what that resource means in medicine and how it is going to be relevant for what they are going to learn in future. So I don't think that there will ever be a time when medical educators can be replaced with technology. probably like you rightly mentioned, the way we mentor students might become different, and what kind of, the type of input that we're going to give them would become different. And especially when we're speaking about VR, I'm also aware of the situation in a lot of medical colleges where there is a dearth of cadavers. There is also one more thing, because we've started doing this ultrasound for regional. It's always a surprise for us. We'll be expecting the nerves to come in one direction in one place, and I think lower limb is pretty much standardized, but upper limb, or the norm itself is we have to be ready for surprises because there is so much of variation in anatomy. But what happens with all the repository that we have and all the VR and all technology, students can get very well versed with what might be normal or what is thought to be normal earlier, because when they dissect also, they're going to be able to see some kind of variation. But at that point, if they don't know the variation and then they are confused, instead of that, they have a complete idea using technology and VR about what is normalcy. And then the facilitators, when they have the time to dissect. So before the dissection, if they can have technology and all of this knowledge, then when they come and dissect, the understanding of what is expected normally, and if they find something abnormal, and what is the clinical relevance, and the kind of discussions that stem out of it, and the kind of applied anatomical knowledge that comes out of it, I think will heavily enhance how students perceive anatomy and how it is going to be in future.
Thank you, Dr. Tilaga. I think if one has done the dissection at least once in the lifetime, that person will benefit a lot more from virtual reality than a person who has never done any dissection. And virtual reality may be very good for showing so many types of variations which can be captured in other modalities of imaging like MRIs and all those things. So we can have a vast bank of abnormalities which probably are not possible to show in the cadavers. So we may end up doing a limited cadaveric dissections but benefit a lot from virtual anatomy. It is going to supplement, and it is going to be an indispensable tool. I think with that, I will say that I am very much for it, and I want to facilitate the development of VR. But then to adopt it as a substitute for dissection, we are not yet ready.
Do we have more questions from the audience, please? If there are no questions, so you have brought out the evolution of VR from the basic visible human project to the hi-fi technology we are using right now. And you have highlighted the issues also associated with the use of VR. Nevertheless, it is going to stay. You have very well justified the topic, sir, within the given time. Thank you so much, sir. And may we request you to accept our felicitation, please.
Thank you.
Thank you, sir. Our next session is on AR in simulation, and I'd like to invite Dr. S.K. Mishra, sir, Professor and HOD Community Medicine and Vice Principal GSL Institutions, to introduce our next speaker.
So good afternoon, everybody. I have the privilege to introduce our next esteemed speaker, Professor Srinu Vutaluru. He is affiliated to All India, the prestigious institute that is All India Institute of Medical Sciences, New Delhi. And he has the credit of devising the low-cost training modules of simulation. And he is currently the chairman of WETLAB of the Simulation Center at All India Institute of Medical Sciences. He is also a founder president of Medical Association for Simulation Training, Education and Research. Then he is the first Indian investigator to perform, publish and establish Sentinel node program in way back in 1999. He has also mentored and trained not only from the surgeons from India, but also from many other persons, Indian Armed Force and the other armed forces like Nepal, Sri Lanka, and other Middle East countries. He has a special interest in breast and endocrine surgery and transplantations, and he has involved in more than 30 batches of MBBS students and surgical residents. I welcome you, sir.
Thank you, Dr. Mishra. Can I have the slides, please? Can you hear me? Hello?
Yes, sir, I can hear you. Slides.
Okay, thank you.
Where are the slides?
Thank you so much.
Abhishek, slide second.
Can you see my?
Sir is going to talk on the topic that is one of the burning topic, that is AR in simulation. Please bear with us for the technical glitches.
Yeah,
We
yeah,
will
I'm
sort it
there.
out.
Yeah. I can see my slides. Hello? Can you hear me, Dr. Mishra?
Yes, sir.
Yeah, I can see my slides.
Yes, sir.
First of all, good afternoon to all of you. First of all, I thank the organizers of Simulcon for inviting me for this lecture. Sorry for the inconvenience caused. I had to attend a wedding in family, so I had to come to Hyderabad, so I'm not able to attend physically this interesting conference. So basically, I'm the last speaker. The advantage of being a last speaker is that in medical education, we tell something like, whenever you make a presentation, you are supposed to tell what you want to tell. Then you're supposed to tell what you have told. So my job is to now give you all a take-home message of what has been discussed in the last 1.5 days. And in cricketing parlance, it will be like I'm the tail-end batsman, so I can hit across the line and close the innings early also. So next slide, please. So today the mandate given to me is to talk about augmented reality. Augmented reality, as Dr. Supe had nicely put it in the debate session, that it is nothing but it is a technology which extends the user's reality using a digital information. Like you have the reality, but you're just extending it by using a digital information. And the importance of augmented reality in medical field has been in the field of anatomy, the physiology, and for surgeons, it gives us what we will do exactly by having a display of the augmented reality in the operation theater. And in radiology also, it is coming up a big way. So almost in every specialty of medicine, the augmented reality is going to be a part and parcel. Next slide, please. So when you look at all the digital or the simulated training, you have on one side the real environment and the other side you have the virtual environment. From the real environment, when I manipulate it, it becomes an augmented reality. And virtual environment, when I try to redefine or I can refine it more, then it becomes an augmented reality. And when you mix both the augmented and the virtual reality, it becomes a mixed reality. So what is the difference between augmented reality and virtual reality? Is that augmented reality is a real world augmented experience with overlaying or mixing the simulated digital imagery. Whereas virtual environment is entire thing is virtual. You get an immersive experience and it requires a handset to replace completely the user's surrounding view with a simulated immersive and interactive virtual environment. So virtual environment is literally everything is virtual, whereas augmented reality is where the real environment has been given a digital boost so that it appears better. Next slide, please. So these are all, there are a number of treatment domains in which augmented reality and virtual reality are used to treat patients when it comes to the healthcare. And among these domains are the pediatric diagnostics and treatment, in the management of pain, mental health, neurological disorders, planning of surgery. As a surgeon, we will have a tremendous benefit of literally doing an operation before actually performing the real operation. And in intraoperative procedures, it can be of great help, especially when you have some difficult localization or complex anatomies, and in the ophthalmic diagnostics. And in teaching, it's really very important because telemedicine, by using virtual reality, you can reach virtually every corner of the country or the world by using the augmented and the virtual reality. And this is also important in providing rehabilitation. Next slide, please. Okay, so this has already been talked about a lot in the last 1.5 days. A simulation is nothing but an imitation of an operation of a real world process or a system over a time. And this has been used a lot in every field, which is could be either economics, the military, or the mechanical or the medical. And the main purpose of simulation is for the personnel training. Uh, Whenever you want to train a personnel and it's a very complicated procedure, then simulation becomes a very good way of doing it. Next slide, please. Yeah. So when you look at the simulation, again, this has might have been talked about a lot, like it is talked about in every simulation conference. Like simulation is closely associated with aviation industry because there one small error can cause disasters. So it is here that simulation has been used very greatly to refine and ultimately make everything accurate as far as flying aeroplanes is concerned. Next slide, please. So in the aviation industry, the first time a simulator was used was way back in 1910. And this was, as Aditya was telling, like everything starts very simple and then becomes complicated. So it started with wooden barrels, then there was a link trainer, and which could move corresponding to the pilot's use of the instruments. So this is how it started, but now it is very, very sophisticated. Same is going to be the case even in medical profession and medical education. Next slide, please. So as technology developed, what happened was that the simulators have also developed. Virtual reality started in 1970s, has now become an important component in simulation. And various industries, including medical field, have started to use these technologies for simulation and virtual training. Next slide, please. So as I said, like the simulation is used a lot across different industries, and one of them is for which is important for is healthcare. Next slide. So when you come to the history of medical simulation, the first thing which is talked about is the Ricci Annie. It was a part task trainer. Part task means only some of the steps of the entire training will be learned on that. And this revolutionized actually the resuscitation training. And these were the first attempts of at simulation, as you can see in these pictures. Next slide, please. So Simban is the one which had actually something called as it could breathe, it had a heartbeat, and it had temporal and carotid pulses which were all synchronized, and it had blood pressure. And the Simban was the one which could open its mouth, close its mouth, blink its eyes. So what was important was this tried to give you a very natural feel when you use it, when you are using the simulators for the medical education. Next slide, please. Now, when you come to the classification of simulators, as has been said, this could be either a part task trainers, that is only part of the entire task is being learned through the simulation. It could be a computer-based system, or it could be literally completely everything virtual and having even haptic touch nowadays. And you can have simulated patients, simulated environments, and integrated simulators, and instructor-driven simulators, and model-driven simulators. So there are a variety of simulators which are currently available for medical education. Next slide, please. So this seems to be a slightly busy slide. Basically, for every task, uh, there is uh, there is a way to do it, whether it could be the physical body, whether it is an automated response, or whether it is a performance feedback or the independence of learning. So based on this, the various simulators which have been available are being classified, and some of them have a very low cost, some of them have a very high cost, some of them need a very intense maintenance. So depending on what an institution can support, we can choose from these simulators. Next slide, please. So simulation in surgical training, this is what is very close to my heart, which we have been trying to develop low cost technology simulators at All India Institute. Simulators in surgery can be divided into two groups, inorganic ones and the organic ones. The inorganic ones can be further divided into either they could be mechanical, or they could be something like a virtual and mechanical, or it could be completely a virtual reality. Next slide, please. So why train on a stimulator? Again, this has been discussed a lot in the previous debate and also over the last 1.5 days. So surgical apprenticeship was one thing which was brought in by William Halsted, who is actually responsible with the current surgery residency program in the United States. And what was thought was that there will be a gradual transfer of tasks and responsibilities to the training residents. However, as the medicine has become more complicated, surgeries have become more complicated, the limitations for this sort of training are becoming more apparent. The important thing is the ethical question of surgery being performed by a novice, and also with the ACGME giving importance to the amount of time a resident can work at a time. There is a reduction in the time of the resident spent in the operating room. And the economic pressures, like operating time is very, very expensive in the US, to the extent that a 1 hour operating time is almost equivalent to a 5-day, 7-star hotel cost there. And increasing medical legal pressure. As you know that more and more digitalization, more and more video recording of the procedure. So these are all becoming, so training on a human is becoming more and more complicated and more challenging. So the other important thing is the development in laparoscopy and robotic surgery. What laparoscopy does is that a 3-dimensional view becomes a 2-dimensional view, and the instruments actually move in a different direction as your actual movement, and you need a very good modified hand-eye coordination. So all of this make a real-world training very challenging, and there comes the role of the simulation and especially the augmented reality. Next slide, please. Can I have the next slide, please? Okay. Sorry, the previous slide. Go back to the slide, yeah. One more slide back. One more. Okay. So the types of, yeah. How does the training in surgery help is that, again, you can take it as cognition, integration, automation. These are the various stages. So as you go through the simulators, but what you want to reach is that everything should happen, as we surgeons call it, as at a spinal level. So you will be able to achieve this goal gradually by using the simulators. Next slide, please. So the introduction of minimally invasive surgery has demonstrated the need for training surgical skills outside the operating room, as I have said, using animal models of the simulators. As laparoscopic surgery involves display of images on a screen, virtual real simulation of surgical task is feasible. And all simulators aim at training psychomotor skills for the patients. So when it comes to the types of stimulators, I think you can go a little slow. Yeah. Type of stimulators, as I said, the mechanical simulators, this is the one which has been used a lot in the last, I think, 15, 20 years, which is now available in most centers. It's a lab trainer with SimuVision. Whatever you do, it will get displayed on a monitor and you can hone your laparoscopic skills using a SimuVision. Next slide, please. So these are the hybrid laparoscopic simulators. One of them is called as a PROMIS. This is a literal augmented reality simulator. Like you can have a haptic feedback and you can see it on the monitor, but you can introduce something called put small bowel in between so that the small bowel needs to be retracted while doing a laparoscopic cholecystectomy. So this is a sort of combination of augmented and virtual reality. Next slide, please. So this is the part of this, what is called as the immersive technology. And as I said, 3 types of the digital simulation training are there: virtual reality, augmented reality, and when you mix both, it becomes a mixed reality. Next slide, please. So this is what somebody was talking about, the extended reality, which is a real life situation, then the augmented reality, and the virtual reality, which get mixed. So which is something people call it as an extended reality. Next slide, please. So actually, all of this has been covered, so I won't go into it. So you can keep moving the slides. Next slide, please. Let us go to, next slide. This has all been discussed, so I don't want to repeat it. Next slide, please. Next slide. Okay, so this is another important thing. Whenever you talk about, just go back to the slide. I'm sorry for the inconvenience. Yeah. See, the most important thing about the currently available virtual reality simulators is the cost. It is a prohibitive cost. Though in the long run, they may become cheaper, and as more number of people use it, it may become cost effective. But as it stands today, having everything a virtual reality simulation training is beyond the economic capabilities of most institutions in our country. Next slide, please. So these are the interface devices which are being used, the interface devices and virtual reality laparoscopic simulators. Next slide, please. Yeah, this is one thing which is being talked about more and more, even in now robotic surgeries. We have something called as fifth generation robot where you can get a haptic feedback by sitting at the robotic console. Next slide, please. So these are the phantom devices. I think it might have been covered. Next slide, please. Next slide, please. Yeah, coming to the simulators. These are the ones which are there. The modular virtual reality simulator, the LS500 system from Ixitat. This is used particularly for cholecystectomies, and it incorporates the training of basic suturing skill, a clip and cast technique, and a peritoneal dissection module for opening the callous triangle. This is a very good system to learn the basic laparoscopic cholecystectomy. Next slide, please. So this is the lab mentor or the Symbionics. Again, it is available in some of the training centers in India. It aims at training both the basic and the advanced laparoscopic skills. And compared to the previous one, here you can learn cholecystectomy with varying anatomy. You can introduce an anomalous hepatic artery. You can introduce a Monnihan's hub, and then train the residents in doing cholecystectomy. Next slide, please. Yeah, surgical education platform is a more advanced the virtual reality training simulator. It makes you learn the port placement, the camera navigation, the basic skills including suturing and knotting, and the tissue dissection procedures. But all of this, as it stands today, cannot be afforded by most medical colleges in our country. Next slide, please. So LabSim is another thing. Next slide, please. Yeah, this is another one which is available for virtual training. Next slide, please. So Window Tower, this is one of the newer ones. Next slide, please. The West system, yeah. This is the one which it has 2 foot switches and are implemented for providing the surgical coagulation function. As I said that till now we were only using the dissection and all. This one incorporates even using the newer energy devices. Next slide, please. This is another one, a virtual reality simulator which has a hardware and a software which aims at improving your hand-eye coordination and a 30-degree laparoscope. See, laparoscopes are of 2 types, the 0-degree one and the 30-degree one. 30-degree one is a difficult to use and difficult to train on a patient. So if you get trained in the cameraman is very important when you do a laparoscopic surgery. So if your assistant gets well trained on a system prior to coming to the operation theater, it will definitely benefit and make the surgery faster. Next slide, please. Yeah, the augmented reality is the one about which I'll talk a little bit. Next slide, please. Okay, this is the one like Dr. Sharif was talking about, the HoloLens and all. These need to be worn when you are practicing it. It's a useful information. It can be projected to the real world. And what you can do is that you can make a 3D reconstruction of the spine, and it may project into the intraoperatively so that you can improve the action, that you can perform the operation before performing the actual operation so that you are better prepared when you actually do the procedure. Next slide, please. So these are the devices which are available. As I said, these are all compared to the virtual reality ones. These are not that very expensive. Next slide, please. Yeah. AccuVein is a projector-like device that displays a map of the vasculature on the skin surface. And what it does is it improves your venipuncture techniques and makes you a better internist. And you can do your procedures much more accurately. Next slide, please. So the applications, as I said, are especially in neurosurgery and orthopedics. Neurosurgical procedures, as you know that looking inside the brain is not very easy. But if you use an augmented reality, the neurosurgical procedures uh, uh, can be done very successfully because there is a lot of movement which occurs in the head and the brain. So this can be overcome by using the augmented reality. And it has been reported the augmented reality has a major impact in 16.7% of neurovascular surgeries, allowing a higher rate of precise localization of the lesions. And also it helped in improving the operative time as compared to the traditional 2D approach. Next slide, please. So the augmented reality has proved to be useful during orthopedic surgeries and reconstructions, especially the dental surgeries also, because it allows to view the reconstruction directly on the top of the patient's body. And this reduces the number of distractions which one can have while performing the procedure. Because whenever you're doing a 2D operation, you have to look onto a monitor and then operate. Whereas here you will be looking on the patient and directly operating by superimposing. So it becomes much more real to what you do actually. Next slide, please. So this is the another one, which is a conglomeration of all three. Next slide, please. So this is what I was talking about. Again, everybody knows it, that something called as augmented reality and virtual reality, and both of them get mixed. It's called as a mixed reality. Next slide, please. So this is the extended virtual and augmented reality in thoracic surgery. This was a systematic review which was published. Next slide. So as I think Dr. Aditya was telling, one of the most important places where you can use the virtual reality and augmented reality is when you try to assess the performance and competence of the residents. And this can be used either in the MISTELs or OSATs or ADEPT, at whichever way you want, you can do it. And the assessment can be very, very consistent. Next slide, please. Okay, now a little bit of literature review, like as medical professionals, we always believe in something called as evidence-based practice. So let us do a little bit of literature review on use of these and what has been found. Next slide, please. So this is one of the studies in the Cochrane library. Actually, I'm not able to read it really well because this was basically a meta-analysis of 8 trials. What it had been found is that whenever you use a virtual reality or augmented reality, then the operating time has become shorter. Next slide, please. Yeah. So this is another study which compared virtual reality training compared with apprenticeship training laparoscopic surgery. This has 24 randomized controlled trials. The control group did not receive any specific training. What they assessed was the time, the path length, the instrument handling, tissue handling, error score, etc. were measured. And these were found to be better in the group which had virtual training as compared to those who didn't have any training. But the most important thing was there is no actual evidence of improved patient safety or improved cost benefit when comparing the both. But what is important is that there's something called as the comfort of a surgeon. If the surgeon feels that he has done it well and is more confident, that is also a very important parameter that has to be taken into consideration when you are evaluating any new system. Next slide, please. So this is another study, laparoscopic virtual reality and box trainers. Here there are 3 groups, lap sim, box trainer, and a control who did not have any training. And when they compared the lab and the sim box, they trained significantly better than no training at the end of 3 weeks. However, in this study, there was no difference found between the lab sim and the box trainer, thus suggesting that any training in any simulation lab prior to doing the procedure definitely makes a difference. Whether you use a virtual reality or a augmented reality or a low-cost technology, if you practice it before, definitely you do better in the operation theater. Next slide, please. So this is one porcine cadaver organ or virtual reality simulation training for laparoscopic cholecystectomy. This is a randomized control trial. This found that there was no significant difference between the groups at retention testing. The virtual training group did not outperform the control group. Here, the control group was the one which had practiced on a simulator. Next slide, please. So this is proving the effectiveness of virtual reality simulation for training in laparoscopic surgery. What they found that there were no intergroup differences in the baseline skills. The first lab colli revealed significant difference between the control and the virtual groups in terms of time, the path length, the number of movements, and the video scores. The virtual reality group achieved the video and dexterity scores equivalent to the level of expert levels of performance. So what you can do know here is that a new performer can perform the procedure as good as a person who has experience, and he will definitely perform better in the operation theater. But this has not actually translated into better outcomes for the patients or in terms of the cost. Next slide, please. So this is another study, the efficacy of virtual reality simulation training in laparoscopy. This is a systematic review of randomized trials. And here they studied the operation time, and they found that it had become lesser by about 17 to 50% in the virtual training group, depending on the simulator type and the training principles. The simulator offered training for complete operative procedures came out as more efficient than simulation offered only as a skill-based training. So what they're trying to tell is that you have to learn the procedure completely on the simulator rather than just getting the basic skills. And skills in laparoscopic surgery have been found to be increased by proficiency-based procedural VR simulator training. And again, nowadays more and more surgeries are performed through the keyholes, whether it is robot or laparoscopy. So this training can be done better if you use a simulator for training. Next slide, please. So this is another study which had 17 articles which were included for qualitative synthesis. 317 participants completed the training in 4 disciplines. And those who had a virtual reality training group, they performed 18 to 43% faster on the procedural time to completion compared to the controls. And the immersive VR trainees also demonstrated greater post-intervention scores on procedural checklists. Again, there is no study of whether it had any better outcome for the patients or in terms of the cost. Next slide, please. So this study actually shows you something called as the MERS score, which is actually the Medical Education Research Study Quality Instrument scores. So whenever you do a medical education research study, you give something called as a MERS, which is a score which you give. So any study which has more than 10.5 is considered as a good score. So in the previous study which talked about, majority of the studies had a good MERS score, thus suggesting that the study is very, very relevant. Next slide, please. Now, how do you assessing the simulators? This is again very, very important thing. Although the intention is to shorten the learning curve on real procedure, there are no studies to data have objectively investigated the degree to which VR simulated medicine can satisfy this demand. In the airlines industry, they found that there is an excellent transfer effectiveness ratio, and it is now possible to calculate the cost time effectiveness in addition to the simulator training program, but this has not yet been done in the medical education. Next slide, please. So, ladies and gentlemen, I conclude my talks by saying that immersive reality is a definite reality in the future training. People may argue that it is not there today. Yes, there are a lot of things were not there today, like robotic surgery. Now, like I know that my son is a surgery resident in US. They do everything by robot in every institution there. So we are not very far behind. We will also go there. Similar is will be the experience with virtual reality training and augmented reality training for undergraduate education. What has been found is that it is extremely useful in initial training. Its use for professionals needs to be explored. It may help them practice on more complex procedures with real-time patient data incorporated into the simulator. So what I was telling was that you can have a lab collie, easy lab collie, then you can introduce the complicated lab collie procedures and you can make them practice. And what has been found is the skill which is acquired in or working on a simulator, it is transferable. With new immersive technologies, the costs may become affordable in the future. Next slide, please. Next slide, please. So what I want to say that simulation should be part of training and not only the training. Nothing can replace, as Dr. Sarif was telling, cadaver dissection. When you get it, you use the cadaver. But before that, they can do a lot of practice on the simulators. Nothing can replace hands-on training under the supervision of the professionals. Thank you very much. Next slide, please. Yeah, thank you.
Thank you.
And sorry for the inconvenience I caused to the organizers. I could not share my slides.
Thank you, Dr. Srinu. It was a wonderful presentation on the various type of reality and how we can utilize it, and it was supported with a lot of research. As we said, rightly, it can be used judiciously, and it will be used as an adjunct to the real teaching methods. In coming days, it may bring revolution in medical teaching, and which we are expecting. There are already it started in postgraduate training. The reality, augmented and mixed reality are there already, but slowly I believe in coming days it will come to the undergraduate teaching also in our curriculum. Now with this, the session is open for discussion. Any questions? Sir.
I think Dr. Sinu, excellent talk. Enjoyed your talk. Can you hear me?
Yes, sir. Yes, sir. I can hear you, sir.
I think excellent talk. I've seen your AIMS VR laboratory. I think it's just superb simulation lab. Have you integrated simulation procedures in your undergraduate and postgraduate program? For example, do you now allow your laparoscopic cholecystectomy training to your first year, second year as per difficulty? Have you really done this kind of an exercise and modules, and do you do it regularly for UG and PG and different subjects?
Thank you, Dr. Supe, for your question. Yes, all our residents now go through the training in our wet lab, sir. They go through the different procedures like small bowel anastomosis, resection and anastomosis, laparoscopic cholecystectomy, and colonic surgery, inguinal hernia surgery. They go through all of them, depending on whether they're in first year, second year, or final year, or they are the MCH postgraduates. But unfortunate thing is that it is not yet part of our logbook, sir. So what we are trying to, that our institute has not yet given the permission. So we want it to be part of the logbook, like it should be made compulsory that they have to spend this many hours in the wet lab. Though we do give them a certificate that they have spent this many hours of training in the wet lab, but this is not yet part of our logbook, sir.
No, exactly, that was what I was saying. AIMS has his own autonomy. So I think you may be the first to really include that and make it kind of mandatory for them to spend hours into simulation lab before they operate on real patients. I think this could be a one step which you would convince your board actually.
Yes, sir. We'll try it, sir.
Srinu, thank you very much. Good to see you. Murthy Andi.
Hi. Hello.
Hi. Finally we meet virtually. Sir, congratulations. That was a fantastic talk, very engaging. Most of the aviation changes were industry-led. Here we are trying to, in medicine, we are trying to make it academic-led. So you are talking about transfer effectiveness ratio, for example, from simulation to actual delivery of service. Now, is there a role, taking from Dr. Supe's, is there a role for us to translate that into organizational simulation? So we can make, say, X number of hours a mandatory item on logbooks, or X amount of simulation work for senior surgeons to avoid lap chole complications, say common bile duct injury, or to avoid hernia recurrence, because we have prediction modelings for all those things. They are very well published.
Thank you, Dr. Muthi, for your question. I think an excellent comment, and what we have said is absolutely right. What Dr. Supe told me last time when he visited AIMS also. But thing is, to get it included in it at institute, no, we have to get the permission from our governing body. So we have made an application for that, and I fully agree that we have to make them work for this many number of hours in the lab before they operate on the patient. But the other thing, as you said, is that lot of research even in medicine is driven by the industry. So I think if industry comes up with better affordable training modules, then I think it should be possible at most centers to make it as a part of the logbook and something mandatory for training for all the residents.
Thanks, Andy.
Any more question?
Thank you.
Sir, I have a question, sir. Can I ask? Sir, actually in being a faculty or trainer in a premier institute, you must be getting the cream of the society as to train. So they are the people who are of high rank and big meritorious students. Now how this training, because all India institutes, they already started long back before the CBME curriculum was implemented. It was started long back, the simulation teaching. Now the ARs and BRs, all these are available in most of the All India Institute of Medical Sciences. My question is, how you see that this training is transforming into the practice?
Actually, we are doing a lot of our postgraduate thesis nowadays are based on the work which we do in the wet lab. We thought that is one of the ways we can push and tell the administration the importance of making this training mandatory. So we have now regular courses for the residents, whether it is first, second, third year or the fellows, and they have to do these courses, and it is entered as a part book, but it is not a compulsory part of our training. That's the thing which we have to try.
Okay. Thank you, sir. If there is no more questions, we can close this session. Thank you very much, sir. It was wonderful.
Thank you so much.
Thank you, sir. I now request Mr. N.S. Murthy, sir, President SHS, and Dr. Gani Sandeep, sir, Vice President SHS, to launch the e-souvenir. I also request Dr. Avinash Supe, sir, to join us in the dais.
Can we launch the souvenir, please?
I think congratulations to the whole team for bringing out this. It's a continuous education into the simulation, which you are the leaders in the country. Thank you so much.
I now request Dr. Ganni Sandeep sir to deliver the vote of thanks.
Okay. Good afternoon to all the delegates and faculty. As we conclude Simulcon 6, I would like to express my heartfelt gratitude to everyone who contributed to making this event a resounding success. Simulcon has always been a platform for showcasing newer technologies and innovations and enhancing our thinking capacities within the world of healthcare simulation. This year, we welcomed yet another milestone in the history of healthcare simulation, and your presence played a crucial role in this achievement. I am sincerely grateful for the gracious presence of our Vice Chancellor, Dr. DSVL Narasimham, as the chief guest, and Dr. Ben Berg as our esteemed guest of honor. A huge thank you to the brilliant minds who led this conference, our patron, Dr. Gani Bhaskara, President of SHS, Dr. Murthy. Your leadership has been invaluable, and it's my privilege to be the Vice President for this esteemed society dedicated for healthcare simulation. A special thank you to our esteemed faculty and EC members who traveled from across India, bringing their expertise and insights into healthcare simulation. Your contributions enriched our discussions and inspired our delegates. A warm thank you to the principal of the institute, Dr. V.S. Gurunath, medical superintendent, Dr. TVSP Murthy, and principals of physiotherapy and nursing colleges, Dr. Apparao and Ms. Ramya and Ms. Geeta, for supporting to make this a huge success. I would like to also extend my appreciation to IT team, Abhishek, and the rest of the team, Mr. Murli, and for the audio visuals, and for their assistance, and Mr. Mani from the photography team for being there around the clock and making this event a grand success. My special thanks to the travel team for the food and accommodation teams, and facilitated by our dedicated volunteers and interns. I also want to acknowledge the efforts of our housekeeping and security for helping us. Last but not the least, thanks to our Smart Lab team, especially Anand, Nirupama, and Shravanti for their excellent coordination throughout the event. We are grateful to our sponsors for using this platform to showcase their innovations, to all the delegates for their enthusiasm and participation. Special thanks to all the students as well who have, for the BPT and medical students who have made their priority to attend this event despite their rigorous academic schedule. So with great excitement, I look forward to seeing you all at Simulcon 7 under Society for Healthcare Simulation. And thank you once again, and bidding goodbye for now. Shibas. Thank you.
I request everyone to join us for lunch in the greenhouse.
Welcome to